Ready to get going. All right, Carissa, good morning. You had logged on earlier, and I just wanted to let you know what was going on. Anita and I have never passed the presentation back between the two of us. We've always had a moderator that's done that for us, and we're going to try doing that this time. So when you logged on earlier, that's what you heard us practicing or saw us practicing, passing this presentation back and forth to each other. That's what we were practicing. Oh, is everybody excited to be here and get ready to go this morning? All right. Go ahead and put me something in the chat box. Tell me good morning. Tell me hello. Putting something in the chat box is the way that is going to let us know that you're present, that you're with us. And we've got a really small group today. We've got two students, actually. We've got Jennifer, we've got Carissa. We've got two instructors. So ladies, it's like you're getting one-on-one this week. And then you've got the bonus of having Diana as an organizer. And then we've got Lynn as an organizer as well. And Lynn's not only our organizer and a moderator, Lynn has taken this course before as well. So she's very familiar with the presentation. I hope you're happy to be here. I hope you've been looking forward to this course and you're glad to begin getting this formal education as an ostomy management specialist. All right, so Carissa says she's here watching from her phone. Oh, iPad issues this morning. Okay, all right. Are you able to see and are you able to hear everything with your phone? Okay.
Carissa, I will tell you that trying to do this class off your phone is very difficult. Joy and Anita do a lot of hands-on demonstration, and it's going to be really difficult for you to follow along and get the full benefit. So I would encourage you to go on to a desktop or a laptop.
Definitely. This is very much a hands-on showing course right here. We pretty much show something with all the presentations. Some people will actually, when they're having problems with their computer audio or something like that, they'll have open their computer and their phone. Would that work if you had your iPad open to the presentation and then maybe your phone for the sound? That might be an option for you to try as well. Yeah, you can work with that. That way you'd have the best of both things. You could see us when we're presenting, but you could also see the screen presentation as well. I know on my phone, it gave me a choice of watching, just the presenter or watching the presentation. But in any event,
Did we get a chat from Jennifer?
Do what? Did I get a chat from Jennifer? Jennifer.
She was on way earlier in the beginning.
She sure was. Hey, there you go. There you go. Are you looking forward to being here, Jennifer? I hope so. Very good. Very good. I'm really, really glad to hear that. All right, without further ado, let me get going right here on the introduction and the welcome. And by the way, at any time, if you've got any questions, any comments, just go ahead and put them right there in the chat box, okay? We've got such a small group, it's not going to be hard for us to take a question right away. So if you've got a question, go ahead and enter it right there in the chat box. I am hoping that this course is going to make a really big impact on your life. Courses like this that, build on your knowledge base already are absolutely life-changing. And I did a good bit of trolling around on the internet over the weekend, and I found that both Carissa and Jennifer are wound care certified already. So that's going to help you a lot during this course, because for ostomy management, there is a component of wound care in here as well. And that's because the majority of the time, when you have an issue with an ostomy, there's a skin issue as well. So this course isn't only going to change your life, you in turn are going to change the lives of all the patients that you're coming in contact with and working with. And another thing, becoming certified in ostomy care, it's going to give you a different relationship with your ostomy patients. You're going to be the resource that this person fully relies on, maybe even the resource for your community. And I just find that my role as an ostomy clinician, it's completely different than my role in any other area of nursing. Now, both of you are already familiar with the Wound Care Education Institute. You're familiar with Donna Sardina over there on the left, Nancy Morgan on the right. And you know that in 2002,
Joy, can you
yes,
please share your desktop? You're not sharing your desktop presentation.
I'm not sharing my desktop.
No,
How did that happen? How did that happen? What do you see right now?
I just see you and Anita's webcam. You're not, go to your share desktop. Or show my screen. Go to show my screen.
And it says show my main screen.
There you go. Now we're cooking.
Wow. Okay. Oh, if that ever happens again, somebody please let me know, because
I'll
I don't.
jump in next time. I thought you were still kind of doing the little mini chat in the morning here. I wasn't ready
No,
for you.
no, I was good and going. I was
I
good.
was scrambling just as soon as you started introducing Donna Cardillo. I'm like, wait a second, they can't see that. Okay, I'm on it there, Joy.
There we go. There we go. Now can you see Donna and Nancy? I think you can see Donna and Nancy. If you can't, you let me know. All right. These are the two ladies that formed the Wound Care Education Institute and started the WCC program back in 2002. And in 2013, they launched the Ostomy Management Specialist program. And I love the name of this certification, Ostomy Management Specialist. It says exactly what we are. And I think the name itself can help bring the patient comfort when we're at their bedside and they see our credentials, like I've got written out on my shirt, and it says Ostomy Management Specialist. They know that there's somebody that's certified in this. They know that they've got somebody specially trained that's going to be able to help them in this area. Now, for this course, you've got 3 instructors. You've got Dr. Don. He's over there on the far right. Dr. Don is a WCC instructor. He is the instructor for the DWC program, the Diabetic Wound Care Program. And he's also one of the instructors for the OMS program, as he does the pre-modules. And I want to say that this is the first time in the whole 7 years that I've been teaching this that we have had 100% compliance with all of our students completing their pre-modules before the course started. So woohoo, ladies, woohoo, woohoo, woohoo. Yes, 100% compliance that you had completed these pre-modules. So very good, very good. But that's Dr. Dawn. That's who narrated the pre-modules. In the middle, you've got Anita. Anita's going to be teaching this week as well. Today, she's going to be doing stoma assessment. So you'll hear from her in just a few minutes. And that's myself over there on the left, but with different hair. Every time you see me, I'll look a little bit different. I'm just always doing different stuff with my hair. Sometimes I wear glasses, sometimes I don't. And I always like to say it's because I've been married. This year will be 37 years for us, and I'm just trying to give that man some variety. So I shake it up a little bit with the hair. Oh, and I gain weight and I lose weight too. Always doing that. Now, if you're wondering what we're going to be doing this week, Monday through Wednesday, it's going to be lecture, all lecture, but we will be doing some hands-on, such as we will be working with the envelope full of samples that you've gotten. And if you would go ahead and get your envelope out, we can take a look and see what you've gotten in there. You're going to see that in your envelope, you have got some stoma caps. We'll look at the stoma caps later on. Also, you've got a little stoma pin. It's in your little baggie. Also in your little baggie, along with your stoma pen, you've got a speedy cast. We'll look at the speedy cast tomorrow. You've got a Calvalon skin barrier wipe. We'll be using this on Thursday when we do crusting. And you've got a sample of a vent. We will talk about the Chem vent this afternoon when we are going over the different kinds of products. Now, what else have we got? You have also got a Living with an Ostomy brochure. We'll talk about that on Thursday. You have got a postcard from the UOAA. The back of it gives you an idea what the UOAA can do to help you. And you've got an index card. We'll be using the index card on lab day as well. And then that leaves us with our Safe and Simple little packet right here. Inside the Safe and Simple packet, you've got some tape. This is the DermaPro silicone tape. You've got 2 of your moldable barrier rings. We'll be using one of the barrier rings today. The other we'll use on Thursday. You've got some odor eliminator. You've got several of the peristomal little wipes. We'll use one of those today when we use your moldable barrier ring. You've got a couple of different sizes hydrocolloid flange extenders. We'll look at those today, but you'll use one of them on Thursday, and you'll have a little sample of powder. We're going to use the powder on Thursday when we do crusting. And then you've got some information from Safe and Simple as well. Oh, and also in there, you've got barrier film. Okay, so that kind of covers your little envelope and what was inside your little envelope. Another thing that was already sent to you is something that we will be using on lab day. And that is your skills kit from the American College of Surgeons. I am really proud that we're using this kit now. It's going to leave you with a little booklet and a DVD that's in there that can really help you with your explanations of what these procedures are. Kind of, to me, it benchmarks what we should be teaching, because this is like an OMS in a box for explaining the different procedures. Okay, so we will be using this skills kit on Thursday. Also on Thursday, we'll be doing the crusting procedure, and I'll use that index card and show you how to hold back effluent. Another thing that we're going to be doing on Thursday is lab, and we'll have a breakout lab where you can step away from the computer. I will still be here if you need to access me during that time, but we'll break away and do some hands-on work with some documents that are going to be emailed to you. It's a stoma assessment, peristomal skin challenge, and a challenge yourself or multiple challenge yourself scenarios. So it's all the documents that you're looking at right there. They will be emailed to you either Wednesday or Thursday morning. And the answers are going to be emailed to you as well later on during the day. Now, also on Thursday, we're going to do a week in review. That's the review questions from all of the end sections of each session that we go over. Very similar to the one that they do in the WCC program, except for this one, I did mix all the questions up. So we're not going, from section to section to section. And there is also extra questions that have been added in as well. Probably about 50 other questions have been added in here as well. Now, this course was based on the current evidence-based practice and standards of care and current research that's available. If you haven't already torn in your workbook, go ahead and tear on into it. We do have a daily schedule, and we do try and stick as close to the times as possible, but sometimes that just doesn't allow. Sometimes we've got more things to show or fewer things to show. There have been a couple of changes in the schedule. You'll see that mainly on day 3. On day 3, we don't do the case study. We actually play a game of Jeopardy later on, and it's a really good review and kind of a fun way to do it. And we'll do that in between the PEDS section and patient education. So I'll have you do that case study day 2 on your own. We do start every day at 8 o'clock, and we are on Central Time. We are teaching on Central Time. And so I think as far as the students, I have got one person who's on Eastern Time, and I think I've got one on Pacific. Is that correct? Would you please put your time zones in the chat box for me? Please put your time zones. Anita and I, both the instructors, we are both on Eastern Time. Yes, Jennifer, California. And Carissa, aren't you South Carolina, Carissa? I was thinking that you were South. Yes, South Carolina, South Carolina. Yeah, I had actually emailed you your envelopes, and I hope you got my email, or I had shipped you your envelopes, and I did send you an email saying that I was the one that had cut into the top of it. I'd forgotten to put the index card in there, and I needed to do that, and I remembered it as I was going out the door, so I just cut right into it and taped it across the top. And Lynn is the one who is on Central Time for us. Very good, very good. And also Diana is on Central Time as well. So if I do mess up and say the time zone that I'm in, Eastern Time Zone, it's because that's written on my screen. But I do have my clock set up there with a little note on the top of it that says Central Time Zone. We will be starting Central Time Zone. We will be going to lunch according to Central Time Zone as well. So I'll try and keep all my times that I'm talking about for the Central. We can do a 45-minute lunch, or we could do an hour lunch. What do y'all think? 45 or an hour? Let me know what you think. And it's totally up to you, Jennifer and Carissa, whatever y'all want to do. It can be an hour or it can be 45. Oh, thank you. Don't have a preference. Okie dokie. Jennifer, how about you? Jennifer, okay, yes, you can. Yes, you can have an hour. I know that sometimes there's things that you've got to get done during lunch, so that's fine. We'll do an hour every day, so that means we'll be finishing at 5 o'clock every day. It's really easy to take notes in these workbooks. They left you a good wide margin. And I do recommend that you take notes with this presentation. I really do. And anything that you feel you might be weak on, make sure that you're highlighting that so you'll know to come back and review it. At the end of each day, there are some end of day review questions that you're going to be able to answer. They're in the very back of your workbook. And the answers are included for you. And there are also back in the back of your workbook some review questions that'll go along with the earlier sections as well. So I do encourage you to work your way through those. As far as the pre-modules, you ladies have completed that, so we don't have to worry about it. But this slide would be letting the people know if they hadn't completed it, they needed to have it done by Tuesday night. Now, this is something we all want to know about. Your CEs. You're going to get 30 CEs for the online part and 6 CEs for what you did with the pre-modules. So it is a total of 36. It's a good amount of CEs, and that's because this is a lot of information that we're going to be covering. As far as the evaluations, you'll see that there are evaluations in the back of your course book. However, those aren't the evaluations that we're going to use. The evaluations that we're going to use are going to be an online evaluation. It's going to be a lot easier for you to fill out. Now, you do want to make sure this evaluation has been completed within 60 days of you completing the course. But I encourage you to complete this evaluation as soon as possible, because as soon as you complete your evaluation, you're going to get your CEs. So you could even do that Thursday night if you get this sent to you Thursday night. If for some reason that you see that, hey, I haven't gotten my evaluation to do, make sure that you email Diana. And you can email Diana at drrip@relias.com. She's not a doctor, by the way, but I tell you, if that was my email, that is the exact way I'd be saying it every time. For this course, after you have taken your certification examination, your credential will be OMS, Ostomy Management Specialist. And your credential will come from the same certifying body that your WCC certification comes from, and that's the National Alliance of Wound Care and Ostomy. And you already know, but the National Alliance of Wound Care and Ostomy is a not-for-profit organization group, and they have got doctors, nurses, nurse practitioners, physical therapists, occupational therapists, everybody covering that board. You can find out more information at their website, www.nawccb.org. And if you haven't already downloaded the workbook, I encourage you to download the workbook. Everything you need to know about the exam can be found right there in the workbook. Some high points I want to throw out at you is the examination is 100 questions. They are all multiple choice. There's no matching, no fill in the blank, no essay questions. You do need to make an 85% to pass it. And like I said, more information, you can find that right there in your handbook. And don't forget, for this course, you're going to have information coming from 2 different entities. You are going to get your certificate of completion from WCEI, and your CEs come from WCEI. When you log in after you've done your evaluation, your CEs will be right there on your dashboard. And then everything about the examination, that is going to come from the National Alliance of Wound Care and Ostomy. Okay, so we are hoping that you're going to have a really good week. Let me ask you something though. Would you be up for a morning review? Have you thought about that? We can begin at 7:45, that's a quarter till 8, and then class could begin at 8 o'clock. Now, if you're kind of iffy thinking, I don't know if I need a review or not, can you answer this? What do the chief cells secrete in the stomach? You want to shoot me an answer? What do the chief cells secrete in the stomach? How about this one? What's another name for the detrusor muscle? Do you know the other name for the detrusor muscle? I bet you can answer these. What 2 types of white blood cells are present in the inflammatory phase of wound healing? Or how does a partial thickness wound heal? If you couldn't answer these questions, consider coming to a morning review. I will be logged in every morning by 7:30, ready to take your questions. And at 7:45, I will begin the review. Okay, so if you have any questions, just log on early. Like I said, 7:30 to 7:45. I'll be glad to take any questions that you have. And then at 7:45, I'll begin a review and I'll start the class at 8 o'clock. Does that sound good? What do you think about that, Jennifer and Carissa? Okay, Carissa, I see that you're still not getting a desktop connection. Okay. Are you okay with the connection that you've got, Carissa? Okay. Okay. See it on the desktop. Okie dokie. Glad you're good now. Glad you're good now. Jennifer, how about you? Any questions? Very good. Very good. Okay, so let's get ready and we will begin with our first section. And our first section is going to be section 9. Adjustment to stoma. And Anita and I are just going to leave our cameras open and we're going to shut each time we're not talking. We'll close off our cameras, but we're going to leave the 2 boxes open right there until we get more smooth with our different transitions as well. All right, so I hope you're ready. We will take a break before lunch and we will go to lunch somewhere between 11:45 and 12 o'clock whenever we finish the presentation. And we will take an hour lunch, and then we will have a 15-minute break in the afternoon as well. So an hour lunch, and then we'll have two 15-minute breaks. That's right. Anita says that you can shrink your screen up and down to expand us, make us bigger or make us smaller. If you have any questions about what you're viewing or what you're not able to view, go ahead and type it right on in. All right, let's begin with adjustment to stoma. When somebody goes through ostomy surgery, it is life-changing for that person. Doesn't matter if they're an elderly person or a child or an adolescent, it's life-changing for the person and actually whoever lives in the home with that person as well. And even though this is life-saving and life-changing surgery, it still comes with a lot of different concerns, like fear. Why? Well, you've been going to the bathroom one way all your life. Now it's getting mixed up. Yeah. Now you're learning a new way of going to the bathroom, something that was just second nature to you before. And, you might just be worried about the change. Am I going to be able to adapt? Maybe it's a physical issue. Maybe this is your parent that's going through ostomy surgery and they have poor dexterity. And now you realize they are not going to be able to empty and change out their own pouching system because these physical issues that they have. So I'm going to have to step in and be the dependent for this elderly person. And think of how that makes the elderly person feel, that they've been independent all of their life of going to the bathroom. And now, because they can't manipulate the bottom of the pouch, they're going to be dependent on somebody else to help them with a basic need. Maybe the concern could be with the social interactions. Maybe this is somebody who works, let's say that they're a pastor or a rabbi, or maybe they work in a funeral home. Both of those, all of those occupations would involve this person working in a very quiet setting. And sometimes stomas can make that loud sound as the stool is coming out. It can be very embarrassing for the person. So maybe it's social interactions that the person has concerns with. It could be a cultural issue. In some cultures, they use their right hand for eating and their left hand for cleaning. That could limit this person to be able to care for their ostomy and do their change with just one hand. So it can be a cultural issue. And then finally, financial issues. And now more than ever, with the quarantine and people out of work, we're seeing issues with people starting to worry about where they're going to be getting their appliances from. So it can be something that's financial. And there are so many people that not only with the whole quarantine issues and unemployment issues right now, people that just don't have insurance or they're unfunded. So they lack the money or the resource to be able to get their hands on supplies. And they're relying on one of the pantries that's around the country. Well, it's going to be up to us to know where these pantries are. So we are going to be able to refer our patients to them. Because having financial concerns on top of everything else that comes with having an ostomy can just be totally overwhelming for the patient. Postoperatively, many patients feel like they've got a loss of confidence, a loss of their independence, a loss of their dignity as well. Ostomy surgery can have such a significant impact on the person's body image and their own self-esteem as well. And it's not just their self-image and their self-esteem, can have effect on their sexuality as well. The person can just have this constant fear of rejection from their friends. Their friends don't know how to cope with the changes the person's had. Maybe they're uncomfortable with the changes that the person's had. They might even have issues with family members. Sometimes when it's a younger person and there's multiple children in the family, and now you've got one of the children in the family that's gone through ostomy surgery, sometimes the other children feel like, well, this person's just getting all the attention. So there can be some family struggles as well. And then some people even feel like they're just rejected from society. It's like, how can I get out and function? You know, the bathrooms are so small. The bathrooms aren't equipped for somebody to be able to go in there and have somewhere to change their pouch. So do you see how somebody can feel rejected? Oh, and embarrassed. Let's get back to the sexuality part of it. And I don't know which one of these people in the photo they're depicting that's supposed to have an ostomy, but I can honestly say that both of these people look terribly frustrated. And think of the fears that would come with the sexual side of having an ostomy. You know, worried about leakage, worried about how the person, your significant other, is going to view you now that your body has changed since ostomy surgery. And of course, worried about a leak during the experience as well. You know, up to 20% of patients that have gone through ostomy surgery are going to have some issues, worrying about anxiety, sometimes depression, and having a adjustment to their new body image. Also, elderly patients, they can have this fear of dependence, of becoming a burden on the family because they're unable to work that clamp. They're unable to work that closure that's on the bottom of the pouching system. So see, that's where we can step in and make a really, really big difference. And it can be something really, really simple, like offering the person a different clamp. You know, maybe they use a Hollister system and they just can't get this clamp to work. Well, maybe if we switch them to a Convatec clamp, maybe that can make a big difference. And if they can't work a Convatec clamp, hey, what about the Coloplast clamp? It's kind of like a barrette. So something very, very simple for us, just introducing a new clamp. Well, it could be life-changing for somebody with an ostomy that's unable to work the closure on the pouching system that they have, and they're having to ask someone else for help. There was a study that was done by McKinsey 4 months after the person had ostomy surgery. And McKinsey's study found that 50% of the people felt like their body was out of control, and almost half the people felt just less confident with themselves. 45% felt like the stoma ruled their life, and actually it's quite a low number. 37% were worried about the pouch leaking. I honestly would have thought that would have been up in the 80s. 23% of the people felt like less of a man or a woman 4 months after they had had ostomy surgery. Everybody's going to react a little bit different to ostomy surgery, and these are some real life comments that have been made. One person said, I had my ileostomy a month ago, and I've become so depressed I thought of suicide. I stay away from people. I don't know how to handle feeling less of a person, and I'm so ashamed I can't even look at myself in the mirror anymore. You know, suicide is something really real for our patients. And year before last, there was a little boy, 7 years old, and his name was Seven Bridges, and he killed himself because of the way that he was bullied at school. Seven had had ostomy surgery from Hirschsprung's disease, or it might have been imperfect. I believe it was imperforate anus. I'm sorry, not Hirschsprung's. He had imperforate anus. He had a couple of different surgeries as a baby and had a colostomy for a period of time. Then his colostomy was taken down, and he had fecal leakage. And he was teased at school over and over and over about how he smelled. And the little boy at 7 years old took his own life. So suicide can be quite real, especially it's not going to be any different in the ostomy community either. Now, this real life comment just totally breaks my heart. I avoid any family or social gatherings because of fear of offensive gas emission. I've not visited any family member's home for more than 2 years. 2 years this person has been staying home because they're afraid that their pouch is going to smell somewhere else. You know, years ago, that was true. Back in the 50s, the 60s, and even into the 70s, probably early 80s too, if you had a colostomy, that fecal odor could permeate through the plastic. But now the pouches, they are designed out of a plastic that keeps the odor on the inside, and there shouldn't be an odor unless you're emptying or removing the pouching system. Yeah, I wish this person knew that. So those are both negative comments. But you know, there are people that the ostomy absolutely changed their life, gave them their life back, such as Marcy from Montana. Marcy says, my stoma is my friend, a beloved, sometimes frustrating and challenging part of my body. It's not a wound and it's not expected to heal, become a scar and fade away and become something I can forget about. Wherever I go, whatever I do, my stoma is right there with me. Marcy from Montana, I actually met her probably about 10 years ago now on Capitol Hill. And she had a lot of blue hair. You see, she's got a little bit of blue hair then. When I met her on Capitol Hill, she had a lot of blue hair. And we both did advocacy for, I believe it was Right Scan, Right Time. I've done advocacy on Capitol Hill about 4 times, something that I encourage you to get big in as well. But Marcy had a very, very positive outlook on her ostomy, and she was actually thankful that she had gone through ostomy surgery because she is a stage 4 colorectal cancer survivor. And if she wouldn't have had her colon removed, she wouldn't be here today. So Marcy's got a very positive outlook on life with an ostomy. And so does Heidi. This is Heidi from Ostomy Outdoors. And Heidi has let me use several of her pictures for this presentation. And I've actually got a picture of Heidi. I don't think I have it in the presentation, but she's changing her pouch as she's hanging from a rock. Yeah, hanging off of a rock, and she's changing into a closed-ended pouch. Heidi does a lot of extreme sports, extreme rock climbing. To me, rock climbing is extreme, so it may not be extreme for her, but it is for me. And you can see that she wears a lot of tactical gear. This gear comes around her waist, and it also has a harness that comes up between her groin. And in her blog, Ostomy Outdoors, she actually has it drawn out. She's got a picture of herself with all of her gear on, with her harness on, and she's got a picture of where her pouch is tucked away up underneath her harness. So it lets people know, hey, you can still wear gear like this if you have a pouch. You know, the stoma is going to take control of the person's symptoms. The person just has to learn how to take control of that stoma and get back into life. Yeah, get back out there and find a new normal. Now, throughout the presentations, we've got a lot of questions that are built right in. And so this is going to help you keep up with the information, because it can actually be harder for some people to keep up online rather than if they were just sitting right there in a classroom. But this is going to kind of pull you back in, and we need everybody to answer whenever these questions come up. If for some reason you don't know the answer, simply put a question mark or a backslash in, a money sign. I don't care what you put in. But whenever we throw a quick question up, respond with something. All right, so this question, post-operatively, many patients report a loss of confidence, independence, and what do you say? What do you say, Jennifer? What happened to Jennifer? There we go. I agree. It is a loss of dignity. It is a loss of dignity. Now, this one, I think I actually have 2 questions. Let me get to my next one. Nope, I've just got 1 question. Let's talk about the different phases of adjustment. Different phases of adjustment. Now, these phases of adjustment kind of remind me of the Kubler-Ross stages of grief that the person goes through. Well, when the person goes through ostomy surgery, they're going to go through different stages or different phases as well. And just like the stages of grief, you know, people go through them on their own timeline. That's the same way as it is with our different phases of adjustment for coming to terms with ostomy surgery. Everybody's different. You know, everybody approaches a situation a little bit differently. For some people, Acceptance can come right away. Take that person who has had Crohn's disease and they're having 30 bowel movements a day. They are literally living their life in the bathroom. Now they have ostomy surgery and they realize, hey, I've got stoma, managing my output. I can get out. I can get back to shopping. I can stand in line again because I'm not having to run to the bathroom. All my output's going right into the pouch. So for some people, this can be a welcome change and they just learn to love it right away. But maybe this is somebody that's had colorectal cancer and they're diagnosed stage 4 and they're wondering if this is a terminal illness. For some people, they will know that it's a terminal illness. And those people can see their stoma as kind of the face of their cancer. Sometimes they can never accept their ostomy surgery. So it can be any time span for a person starting to accept it from right away to actually never. The first phase is called the impact phase. Bam! Yeah, it's kind of a shock and panic phase for some people. They realize, hey, there's changes to my body. There's changes to my body, and they can be devastated. They can be in denial, and they can actually reject the support that you're trying to give when they're in that impact phase. So what we want to do is be supportive and have that caring attitude and encourage them to participate in the training that we're trying to give. Typically, this can last for days or it can last for weeks for somebody. After the impact phase comes the retreat phase. Some people call the retreat phase the defense or the denial phase. When somebody is in this phase, typically they can be angry, they can be irritated, they can tend to isolate themselves, just give me some time with this. And they can actually deny the reality of what's going on with them as well. Just give me a break here. Just give me some time to adjust. Many times that's how that person feels. They're just not ready to accept the training that we need to be giving because, hey, we've got a timeline here. So we've got to balance this out. And if we do try and insist on training them, many times they don't remember it. So you want to be supportive and realize, hey, this is normal for people to feel this way. And then we get to the retreat phase. Or while we're in the retreat phase, you can tell that this phase is starting to subside because the person's going to start asking questions. And usually the questions are going to be something like, are you going to give me your contact information? You know so much about ostomies. Yeah, they begin to ask questions. Okay, where am I going to get my supplies? Now, if this phase hasn't resolved before they leave the acute care facility, we need to make sure that this person is going to be followed up after they leave the facility. After the retreat phase comes the acknowledgement phase. To me, the acknowledgement phase, they're acknowledging the changes that have happened to their body. And this can sadden some people. Maybe this is somebody who didn't have any scars on their body before, and now they've got a really large midline incision and a stoma over to the side. And depending on how that stoma looks and depending on if this is a woman or a man, it can be very traumatic for that person to find. Like if it's a woman, and she's got a protruding stoma, one that protrudes off the body, that can be shocking for her. They can be mourning the loss of the body that they had before. Like I said, maybe the one that had no scars on it before. But they do realize, hey, all right, I gotta learn some new skills here because I'm gonna be the one who's got to take care of this. During the acknowledgement phase, you want to focus on the person, not just their stoma, and be empathetic to their feelings. And what can be very handy is having a visit from another ostomate. Now, ostomate is a term that you can use to refer to someone who's had an ostomy. It's okay to use this term. Some people aren't comfortable with the term. To be honest, it's not a term that I use a lot. You're going to see the word ostomate on the screen, and you're going to hear me say somebody with an ostomy. I don't know why, but that term just doesn't fall freely from my mouth. It's okay to use it, and it's okay not to use it. I want you to go with whatever you feel comfortable with. But the visit from another ostomy, let's talk about that, because here we got Marcy again. Marcy is in here seeing this man after he's gone through ostomy surgery. Okay. Visit from another ostomy. The reconstruction phase. Now, the reconstruction phase comes after the acknowledgement phase. And finally, in the reconstruction phase, we're seeing periods of acceptance. They're willing to learn. They're more independent as well. During the reconstruction phase, this is when the person is going to return to their new normal. And this phase can last for months, or it can even last for years. Now let's talk about some interventions for adaptation. And you know, not everybody after they go through ostomy surgery is going to be sad. Some people, it can make them absolutely more outgoing, such as the person on the screen right there. This is Melissa Marshall. And Melissa Marshall actually got to grace the cover of the Phoenix magazine issue before last. Here she is. Melissa is an entertainer. For years, she's worked in Atlantic City. She's got the voice of an angel. For years, she's worked in Atlantic City, and she was diagnosed with stage 3 colon cancers. Quite the surprise to her. Quite the surprise. But she's handling it well, and she has become quite a fierce advocate for people living with an ostomy. We'll talk more about Melissa later on. You know, for our patients, we have to plan the care for each person, and everybody's going to be a little bit different. We have to get in there and determine, what does this person already know about ostomy surgery? And is it factual? You know, did they know about Aunt Mabel, who had ostomy surgery back in the 60s, and all they remember is, hey, Aunt Mabel's house smelled like poop. I hated to go over there. Like I said, that could have been true years ago, because pouches back then were not what pouches are now. You also have to, when you're planning their care, determine what the person wants to know and what they're ready to know. You know, we can't go in there and just overwhelm them with this information. So many times that happens. We don't mean for it to happen, but it does. We want to try and prevent that from happening. Our goal is that this person is going to be able to take care of their own ostomy needs on a day-to-day basis. They're not going to be having to call somebody every day and say, okay, what do I do today? What do I do? I'm having a problem. What do I do? We want them to be self-sufficient in taking care of their own needs on a day-to-day basis. But we do want them to have somebody to reach out to, or an organization to go to when they have questions. We want them being independent. And you know what? We want them to be able to recognize when they're having difficulty in that peristomal plane. We want them to be able to recognize peristomal skin complications early, so they can take care of them and they don't become, you know, full thickness ulcers, full thickness wounds. And we want this person to regain a positive quality of life. It's very important that our patients know that we want to hear any questions that they've got. There's not a stupid question. Ask us your questions. And it's very foreign to them. Like I said, they've been going to the bathroom one way all their life, and now it's been changed. We want the person to know whenever they have issues like reddened peristomal skin, seek help early. Don't wait until you've got an open area, a raw area, or much worse, an ulcer. Some people are afraid to ask for help. We want to make sure that all our patients are aware of the United Ostomy Associations of America. And I've given you a little bit of information that was in your sample folder. The back of the postcard can tell you everything that the UOAA can help us with. Their website's very easy to find, ostomy.org. Ostomy.org. When you call the UOAA, somebody is there to answer the phone. And many times they can answer the question that the person has. If they can't, they can put you in touch with somebody else that will be able to answer the question. There's a lot of your brick and mortar support groups around the country. involvement in a support group can be so key to the recovery and so key to this person getting out and finding their new normal. The ostomy support group that you're looking at right here on the screen, very small support group. There are actually 4 women in this support group, not counting the lady standing there in the blue shirt. That's Kathy, and Kathy's actually the president of my ostomy support group, the one that I started. I say mine, I don't mean it's my personal group. It is the one that I started in Moultrie, Georgia, but Kathy's the president. And there were 4 ladies in Lakeland, Georgia, a town that's so small, they just got their first stoplight. They literally did just go from a blinker light to a stoplight this month. There's 4 ladies in that town that have ostomies, and 2 of them aren't able to travel the hour trip that it would take to get from their town to where we hold our ostomy support group meetings. So Kathy started a small ostomy support group in this small town, and she's servicing 4 different women there that love to come to these meetings. And they all have a sense of kinship with each other, mutual respect, and they're there supporting each other. I've got to say that the ostomy community is one of the most supportive communities that I've ever been a part of. I don't have an ostomy. Nobody in my family has an ostomy. I am very drawn to this, but nobody in my family actually has an ostomy, and neither do I. Not only are there your brick and mortar support groups, we've also got a lot of online support groups. There's probably around 2,000 Facebook ostomy related groups now. Anita and I did a poster, it's probably been about 4 years ago now, of the phenomenon of Facebook with the ostomy community. And at that time, we found about 1,200 different ostomy support groups online, big groups, small groups. And this is an example of one of the ostomy support groups. They encourage people in this group, and actually they opened it up to several other groups. If you wanted to post a picture of yourself, go ahead and post it. And they made a collage with it. It was in 2013 that this was done the first time. In 2013, it kind of opened the door. There were some things that happened, and it just opened the door, and there was a kind of coming out of the closet moment for people showing their pouch. And that's when you started seeing all these pictures spring up with people standing there in front of their bathroom mirror in their underclothes showing their pouch, or standing there lifting their shirt and showing their pouch. Now that hasn't been going on for a long, long time, but I would say that the dam definitely broke and opened up on that in 2013. The person that goes through ostomy surgery, and I'll go ahead and expand this to say that they're caregivers as well, need to be able to vent and express their feelings of ostomy surgery, whether it's fecal or a urinary diversion. That person and the caregiver need somebody to talk to. And we need to remember that whenever we're making choices about the person's products, to include that person in these decisions as much as possible. And as far as that goes, we want to include them in any decisions that have to do with their ostomy and their ostomy management as much as possible. We want to empower this person by helping them get a good night's sleep. We might be talking to them about different positions that they may need to lay in. You got your stomach sleepers out there, and when they go through ostomy surgery, they're not going to be able to sleep on their stomach anymore. So it might be little tips, tricks, or finding products that can help this person get a better night's sleep in whatever position they're in. You want to encourage that person, when they can, start back with their routine, start back exercising as well. And something, when we are talking about sleeping, let's go ahead and mention caffeine. Caffeine is an irritant for your bladder and for your bowel, and it will usually make the person more productive. And when we're talking about more productive with a fecal output, that can affect whenever you're going to be changing your appliance. So the person needs to experiment with caffeine. I'm not going to tell anybody they need to quit drinking coffee, but I will say you do need to experiment with caffeine. See what your limit is going to be before you go out in public. The reason I'm saying that is I had a patient that came to see me one time. I have a small clinic here in South Georgia, and I had a patient that stopped at one of the coffee stores and got one of those mocha choca horse, big old things of coffee, and she drank it on the way here. It was about an hour for her to get to my clinic. And when she got here, it took about 6 hands to stop the output coming out of her ileostomy. I tell you, it was like her stoma was a hydrant or something, just spewing the output out. And it had to do with all the caffeine that she drank. So you do have to be careful with that. Now, something that I always do is encourage the patient to name the stoma. And the reason I encourage them to name the stoma is so they'll have something to call it rather than it. You know, if you don't, you're just going to be referring to it as the stoma, or you'll find yourself referring to it as it. So have them choose a name. And when they do choose a name, I always recommend that they choose something positive. Yeah, choose something positive. Stanley, Stella, Scarlett, Ripley, Stomaroma, Rosie. Rosie is a very common name that's used. All those are good, positive names. Bob, standing for butt on backwards, B-O-B. I've heard that one a lot as well. I have had men that have named this after their ex-wives before, and women that have named this after their ex-husbands. And I had 2 women that actually named their stomas Lucifer. And both of these women had been diagnosed with stage 4 colon cancer. They did both know that this was going to be terminal, and they saw their ostomy as death, basically the Grim Reaper. Both of them named it Lucifer, and I didn't try and change their minds. But I just kept thinking to myself every time I heard that, oh, I wish they would have named it something else, because they'll never come to terms with this. And they never did. And it wasn't my place to try and make them come to terms with it either. But I do encourage a pretty name. That's what I would name it. I name it something like Maybelline or Delta or Dixie. Yeah, I'd give it a name like that. I sure would. Now, this is really cute. This girl put this up on social media, and within a minute of seeing this, I had fired off a private message and asked her if I could use this in teaching. Because this girl, yeah, she was seeing some humor in her new stoma. She felt like her new stoma looked like the lips of Jessica Rabbit. I thought that was really cute, really cute. You know, humor can go a long way, especially in the ostomy community. And Brenda Elsiger, that's who's pictured over there on the left, these are 5 of her books that she's written that are centered around ostomy life. And the one in the center of the screen, it's in the bag and under the covers. This is a book that I highly recommend that you get your hands on and you read as well. This is about the person's sex life with an ostomy. And it's not just written from the patient's perspective. There's a couple of significant others' perspective of life with an ostomy in the bedroom as well. There are short little stories in this that will just make you laugh. And there's stories in this that'll make you cry as well. You can get Brenda's books from Amazon, and you can also get them from livingandlaughing.com. livingandlaughing.com. I'm not sure if that's in your workbook. I don't think this book, it's in the bag and under the covers, is written in the workbook. So I really encourage you to get your hands on this book and read it. It definitely was an eye-opener for me. I thought I knew a lot about ostomies, but not this part I didn't. I sure didn't. Other bits of ostomy humor. This is Joe and Danielle, and they have double bag in it. Both of them have 2 pouches. And so they're just an online double bag in it resource. Humor can go a long way with the ostomy community. It really can. And that's not making fun of somebody with an ostomy. I don't mean that at all. I just mean, you know, making fun of life in general. Here's Heidi again, talking about returning to a new normal. And you know, people are going to return to their new normal in their own timeline. There's not a definitive timeline. You reach it on your own. But for us to be able to benchmark our patients and know where they are in this adjustment, there's something from Coloplast that can help us. It's a questionnaire called the Stoma Quality of Life tool. And it can help us identify areas of anxiety or concern. As I said, this is free to us from Coloplast. There's been study after study after study that have proven if the patient is in contact with a clinician that is well-versed, well-educated in ostomy management, they're going to do better. There was a study that was done several years ago. This was before the creation of the ostomy management specialist, back when there was just the WOCN community taking care of ostomy patients. And they looked back on 743 ostomy patients. So they did a follow-up study. This was done by Paula Irwin Toth, and she found that of those 743 patients, only 13% had regular visits with an ostomy clinician, probably because of so few ostomy clinicians that were available. 57% had last seen that ostomy clinician more than 12 months ago, and 32% of the people had never even seen an ostomy clinician. In this study, they found that 61% of the participants had a peristomal skin disorder, and 32% of those were not even aware of what a peristomal skin disorder was. They simply thought, hey, look, you know, I'm wearing this adhesive that's stuck to my body 24/7. I'm going to have skin problems. Well, nay. No, just because they've got an adhesive stuck to their body, that does not mean that they're going to have peristomal skin issues. But it does tell us that we need to continue support and guidance and education for our patients. You know, it needs to start in the acute care setting when the person has their surgery, and then it needs to follow that person wherever they're going, whether it's home or long-term care. And we need to make sure that we're coordinating communication between the settings as well, because it's our responsibility as an ostomy management specialist to help this patient and help their family as well in this challenging journey of finding their new normal. Ostomy surgery can change the person's life, and it's meant to change it for the better. I'd like to introduce you to Blake Beckford. Blake is from the UK, and he always imagined himself as a fitness buff. Yeah, he wanted to get in the gym and work out, but Blake has Crohn's disease. Blake did end up having to have ostomy surgery. Here he is with a stoma. Guess what? That stoma gave Blake his life back. Yeah, he was able to get into the gym, and in he went, and bam, look at him now. You're like, yeah. Well, I will say that that haircut, that fancy tat right there went a long way. But look, he has totally transformed himself. That's from desire. That's from desire of wanting to live a better life. Yeah, and his ostomy is allowing him to do that. A journey of 1,000 miles starts with one step. Just one step. Okay, we've made it to the end of that section. Do I have any questions, ladies? Carissa, Jennifer, if you got a question, if you don't, just put an N right there in the box and I will move on. If not, I'm just going to keep asking you questions. You got it, you got it, you got it. Carissa's good, Jennifer's good too. All right, so I'm going to ask you some multiple choice questions here. Ostomy surgery can and as I said, if you don't know what the answer is, you can put a question mark in there or a backslash, but you don't have to. That's it. Ostomy surgery can mark the beginning of a long path of treatment. That's good treatment. Be the end of years of intervention, medication, and treatment, and mark a return to a more normal lifestyle. The first phase in the adjustment process is called, what's it called? The first phase is called the impact phase. That's right, the impact phase. A sign that the retreat phase is subsiding is the patient. Jennifer, we're gonna act like that didn't even happen, honey. We're just gonna keep act like it. If you answer it wrong, we're here learning. Big deal, big deal. Just come back and answer it the correct way if you want to. All right, a sign that the retreat phase is subsiding is the patient, begins to ask questions. Begins to ask questions. And probably the first questions they're going to be asking for your phone number. That's probably it. Mourning the loss of a body part is thought to be part of which phase of adjustment? Yeah, acknowledgement. Acknowledgement. It's like they're acknowledging this change in their body. Patients with stomas will resolve all their psychological issues with this life-changing event if given enough time. You can put a T or an F in here. That's correct. It's false. It's false. Some people never do. Some people never, ever come to terms with it. It's devastating when we have that, but some people never do. All right, what's the name of the tool that can be used to monitor how your patient is adapting and thriving after ostomy surgery? That's it. The quality of life tool. The quality of life tool. All right, I've got a 65-year-old patient with an ileostomy for bowel cancer, 6 weeks post-op. He's experiencing withdrawal from his family and his friends and refuses to care for his stoma. His wife's concerned he's not coping well, so you advise. Monitor the situation carefully in a visit from that UOAA volunteer. Very good, very good. I want to do something before I switch it over to Anita. I want to do an introduction. I realized I just jumped right on into this and I didn't introduce myself. I didn't give Anita time to introduce herself. So I'm going to kind of do it right now. A quick introduction on myself. My name is Joy Hooper. I think it says Joy on the screen. I'm from Tifton, Georgia. So I'm from beautiful South Georgia, beautiful weather today. I have been a CWOCN since 2001. I got into it because of ostomies, actually. In 1998, I was working on my bridge from LPN to RN, and my very last patient went through ostomy surgery. And I went through the OR and watched him go through the surgery, and for me, it was life-changing. And I knew what ostomies were. I'd taken care of ostomy patients, multiple times as an LPN, but watching the surgery was life-changing. One thing about it was I understood how the surgery happened, seeing it from the inside out. And I remember in the OR thinking, they're teaching us this surgery wrong because it makes perfect sense when you see it from the inside, the out of the body. But just looking at the pictures in the textbooks, I didn't get it. And I didn't really understand differences of why some stool would be so caustic and some stools smelled like poop. Yeah, but seeing it from the inside made a really big difference. And that day, in September of 1998, I realized I wanted to be an ostomy clinician. Didn't know what it meant at that time, but that night I found out to do that I was going to have a bachelor's degree, and I was working on my associate's degree at the time. And I still remember very well walking in and telling my husband, I know you think I'm going to go to work in 2 weeks full time, but I'd like to keep going to college. I need to go to college for about 2 more years, and then I need to go to one of 5 schools in the United States because I want to learn how to be an ostomy clinician. And when I do this, I'm going to be able to learn how to be a wound clinician and a continence clinician too, something I feel very strongly about. And he was supportive then and said, well, all right, if that's what you want to do, that's what we'll do. And I just kept trucking forward, trucking forward. And I tell you, it was a long time. It was a long time working on getting the bachelor's degree just so I could become certified in wound and ostomy care, but it was worth every moment that I put into it. Absolutely every moment. Becoming certified in ostomy care and wound care has been life-changing for me. And I hope it's been life-changing for my patients as well. I guess that's enough about myself. Anita, can you take off your sticky note and tell us about yourself? Unmute yourself.
Hi, my name's Anita Prinz, and I'm also certified wound ostomy continence nurse for about 20 years. I live in Florida. I'm Eastern time. I do want to say I am also very passionate about ostomies. I mean, like Joy and I are like soul sisters here. And I got into it when working in home care in New York City. I didn't know much about ostomies, and I was so fortunate that I had 2 ostomy nurses, WOCNs, at my agency, and they taught me everything. And then one day I went into them and I said, oh my God, when I grow up, I want to be like you. And they said, but you can, and go to school. And so I did, and I went to MD Anderson enterostomal therapy school, and I've never looked back. It's been the best decision I've ever made, for sure. So so that's it about me. I also write for the Phoenix, which is the Journal of the United Ostomy Association. I have about 15 articles with them, and I do blogs, and I do private consulting as well as teaching. So, and I'm also an OMS and a WCC.
All right, and now we are going to turn the presentation over to Anita. Anita is going to do stoma assessment. And she will have us do a little break. Anita, you can call for the break around 10 o'clock Central Time. That sounds good for you.
Okay. Yeah, I have my my clock set for that. So, all right. So let's get on with
To make her a presenter.
Thank you. I'm gonna show my screen. Show my screen. And I have the stoma assessment. Slideshow from the beginning. Okay. So, can you see the screen? Yes?
Yes, we can.
I can't. Why can't I see it? Screen sharing. I don't see it.
Open up screen sharing and click on my screen.
Open up screen sharing. Show me my screen.
Main screen.
Change presenter.
We already did that.
Okay, show my screen. I only see me. And now it's not able to go forward. So, is that the first screen? So, I think that's, yes, okay. So, the definition of stoma assessment is basically any assessment is the collection of data. So what are we doing? We're going to assess the status of the stoma. We're also going to assess the peristomal skin, and that is the skin that is all around the stoma. And this is, how do we do this? The way we assess everything, including wounds, you've done that. Now we're going to assess a stoma, and we're going to look at it. We're going to touch it. We're going to listen to it, and we're even going to smell it. And that sounds really weird. And one of my experiences is that I believe I can smell cancer. in the stool. It's very strange. So, and so the purpose of doing this assessment is to identify complications.
Anita,
Yes?
can I ask you, have you advanced your screen? Because we're still on the stoma assessment cover screen.
I am. Oh, yeah, no, something's not right. I have been. Hold on one second. Yes, I have. Let me,
Okay, so what I'm going to do is take presenter away from you and then give it back to you if you just give me a moment.
okay. Have you done it?
Just a moment.
Okay.
Okay.
Oh, I just noticed at the top it said I was hidden.
Yes. So now share your screen.
On my
There
screen.
you go. Now you go into presentation mode.
Okay. How come I can't see myself though?
It doesn't matter right now. Let's try and get our presentation going.
Thank you. Okay. Okay, so I was saying here in the stoma assessment, we're collecting the data, we're looking, smelling, touching. And then here, can you see, are you seeing the,
Yes, we are. You need to start the slideshow. Slideshow?
yes, from beginning.
Okay, now advance to the next. There you go. We're good.
Okay, thank you, sorry. Okay, so we want to identify complications, okay? And so what we're looking for is any changes in the stoma, and this is especially important in the acute care. And this is also going because we want to look to see that the stoma is viable in acute care, and we'll talk about that later. And then it also is going to help us to determine what type of product this patient needs. Okay. Why am I not advancing? Ay, ay, ay. Sorry, this is not right. So in the acute care setting, we want to assess the stoma every 4 hours for at least a 24-hour period. And you know, if you're going to be the ostomy specialist in the hospital, there's no way you're going to be able to be there every 4 hours. You're going to probably assess it at least once that first day post-op, and then you're depending on the other nurses that are in the ICU, or usually they're in the ICU the first day. And then after that, we're going to check it every 8 hours and as needed. You're going to be checking on that new ostomy patient probably every day in acute care. And in home care or in clinics, you're going to check it every time they come in to see you. So a matured stoma, we're going to change. And again, this is your clinic patient every time we change the appliance. And also we're going to document weekly. If they're on home care services, we want to assess it weekly. And again, in the hospital, if they have extended, you're definitely going to measure it and assess it weekly. In the back of your book, there's an appendix, and there is a stoma assessment sheet that Donna and Nancy developed. There really is no exact document for this. So it's not copyrighted. You can use this. You can make up your own and adjust it however you like. But these are the things that we're going to look for when we do the assessment. And we're going to go over all of that now. So the ideal stoma The perfect stoma that we see in all the books, like this lovely little rosebud, is moist, round, and beefy red. It's sort of a budded shape, similar to a rosebud, and it should protrude about 2 to 3 centimeters. And then we want a flat surface around it, at least 2 to 3 inches. That's what we like, and that's what is ideal. But it's not always what we get, but just so you know. Again, this perfect little stoma is away from any belt lines, any bony prominences. It's not close to your suture lines or the umbilicus. And the lumen or the os is right dead center, right in the middle, and that the patient can see it. So it's usually in a lower quadrant. Any questions so far? It's a perfect little stoma. You're not going to see, unfortunately, that many of these, but we love it when we do. So how do you assess this stoma? You want to be methodical about your assessment. You want to set up your own routine. But one of the best ways is to start in the center and just move outwards. So you're going to start, where is the os? How is the mucocutaneous line? How is the peristomal skin? What color is it? And you're going to figure this out pretty quickly. Okay, so types of diversions. Each different type of diversion, fecal, urine, has kind of the same stomas but different. So let's go over that. A colostomy is going to be described by Joy now. So get ready. Joy has the anatomical apron, and you're going to see several demonstrations by her now. So here we go.
A colostomy is a surgical opening into the colon, also known as the bowel or the large intestine. But before I explain a colostomy surgery, let's review digestion to help understand how this surgery can affect our body. When we eat, we chew our food, it goes down our esophagus and into the stomach. In the stomach, the food is held and it's churned and it's met with digestive enzymes and then slowly released to move into the small intestine. And as it moves into the small intestine, more digestive enzymes are added in to help break that food down so the vitamins and nutrients can be extracted and used for fuel for our bodies. You can say that the small intestine eats for us. From the small intestine, the chewed food moves into the large intestine or the colon. Now, like the small intestine ate for us, well, the large intestine is going to drink for us. It absorbs the liquid from the liquid that we drink and the liquids in the food that we eat. Then the remaining chewed up food moves through that colon and exits the body through the anus. Now let's review colostomy surgery. A colostomy is a surgical opening into the colon. It can be anywhere in the colon. The surgeon will separate the GI tract and either remove the remaining section or suture it closed. Now, to allow the stool to exit the body, the surgeon will create a diversion by making a small incision into the abdominal wall. And then the surgeon will pull the open end of the GI tract out through this small opening on the abdominal wall, fold the GI tract over, suture it down to the skin, and create the stoma. This is where the stool is going to exit the body, and the person can wear a pouch over it to collect the stool. Again, this is a colostomy. An alternate type of stoma that could be created is called a double-barreled stoma. And a double-barreled stoma actually has 2 openings. Now, double barrel could be done in any part of the GI tract. I'm going to show it in the transverse section. After the bowel has been separated, the surgeon is going to bring the functioning end of the GI tract out onto the abdominal wall, fold it over, suture it down, make a regular stoma, an end-type stoma. And the person's going to wear a pouch over it to collect the output. But since we've got a double-barrel stoma, there's going to be the distal end that's going to be brought out onto the abdominal wall as well. Now, the distal end is going to be able to discharge mucus. And in the postoperative period, it can discharge a great deal of mucus. So the person usually is going to wear 2 complete pouching systems. But a couple of weeks later, usually the mucus decreases and a person can simply wear a small little stoma cap over the mucus fistula. Again, this is a double-barreled stoma.
Okay, so how was that?
Actually, Anita, the video does not come over very well. I wanted to let everyone know I will be sending you the links, and you can view them possibly during your break or during lunch. So I'll send everyone the links right now.
So was that the same? And I don't know why I can't advance.
My name is Julian, and I've
Oh,
been paying
whoa.
now.
What the heck?
Regardless of ability to pay or travel.
Escape.
We want to do
Stop sharing your screen and then share it
I'm
again once you
trying.
hear. There you go. I'm
And,
seeing it now.
Oh my gosh, look.
Could you close all of that?
Yes, I'm trying. Oh, done. Oh, what a night. I'm so sorry, peeps. Okay. Okay, so assessing the,
You have to put it in the, yeah, there you go, the slide.
okay. Okay, so the ascending colostomy, back on track, is going to be on the right side of the abdomen because that's where the ascending colon is. This stool is usually very liquidy and mushy because it just came out of the small intestine, so the colon hasn't had a chance to absorb much of the liquid. And this tends to be a high volume. We don't see this very often. This type of stoma is usually done in an emergency or due to cancer because of other obstructions or whatnot. The transverse colostomy is done on the upper abdomen. I find this usually right dead in the middle or a little bit to the left or right side of the umbilicus, and the effluent, it tends to be pasty and soft. Frequently, I see a loop stoma for the transverse, and this particular stoma has the highest incidence of prolapse, which is a stomal complication we'll talk about later. The descending colostomy is the most common. This is on the left lower side of the abdomen, and the effluent tends to be formed and solid. I see a lot of mushy stool, and again, it's going to depend on what they're eating. These people tend to have maybe 1 or 2 bowel movements a day, and this is a nice stoma photograph here, you can see, and it's usually an end, and on the bottom you can see the remainder of the colon is closed, and they call that a Hartmann's pouch. The sigmoid colostomy is also in the lower end on the lower left side, and it's part of the descending, same as the descending colon, even more formed and more solid. This is a photo of a loop stoma. Don't usually see this in the sigmoid colostomy. It is usually typically an end, so keep that in mind. An ileostomy is where we do see a lot of loops, and Joy's going to describe that here. Hopefully no glitches again. Oh, what am I doing? I'm sorry.
An ileostomy is a surgical opening into the ileum, the last section of the small intestine. Now, this surgery brings about big changes to the body, so let's review the functions of the GI tract so we'll better understand the surgery and how it can affect the body. When we chew our food, it goes down our esophagus and into our stomach. The chewed up food is going to be propelled by a muscular movement known as peristalsis, which is going to help push the chewed up food through the GI tract. The GI tract secretes mucus to help lubricate, protect itself, and keep that food sliding and moving along. In the stomach, the chewed up food is held, and stored, and churned as it's met with digestive enzymes, and then slowly releases that chewed up food to go into the small intestine. As it moves through the small intestine, more digestive enzymes are added in from the liver, the gallbladder, and the pancreas to help break that food down. The vitamins and nutrients are extracted from that chewed up food in the small intestine. You can say the small intestine eats for us. You know, this is a caustic environment, the small intestine. This is where cabbage, steak, and pasta are being pulverized, being liquefied, so the vitamins and nutrients can be extracted. Now, from the small intestine, the chewed up food moves into the large intestine, or the colon. I said earlier, the small intestine eats for us. Well, the large intestine drinks for us. It absorbs the liquid from the liquid that we drink, and the liquid out of the food that we eat. And of course, the more colon that we have, the more opportunity for absorption the colon's going to have. Now, the remaining chewed up food moves through the colon and exits the body through the anus. For an ileostomy, the surgeon separates the GI tract in the ileum section of the small intestine and either removes the end section of the GI tract or simply closes it off. And then what's going to happen is the open end of the ileum is going to be brought out through an opening on the abdominal wall, folded over, sutured down. The person's going to wear a pouch over it to collect their stool. This is an end stoma from an ileostomy. Another type of stoma we frequently see with an ileostomy is a loop stoma. For a loop stoma, the surgeon pulls a loop of the GI tract out onto the abdominal wall through a small incision. Then the surgeon generally uses a rod to help support that loop of bowel and prevent it from falling back into the GI tract. And of course, this loop of GI tract is going to be split and sutured open to allow the bowel contents to empty. Now I'm going to use this little piece of intestine to show you how they can form this loop stoma. Okay, so they bring this loop of bowel out onto the abdominal wall. The rod is placed to keep it from falling back in. The surgeon's going to make an opening. Now when the surgeon makes this opening, you see that I'm going to have a proximal end and a distal end. Sometimes the surgeons leave it like that. And so sometimes it can be really difficult to see where the openings are. And sometimes the surgeons perfect it up a little bit more and the openings are clearly visible. And then other times, the surgeons perfect this a little bit more and bring it out onto the top of the abdominal wall, and it kind of looks like a little snout that you can see your proximal and your distal openings right there. Again, sometimes the surgeons will put the two of them together and they can resemble double-barrel stomachs that sit side by side. Now, most surgeons agree that the loop stoma is going to be easier to take down in the event that this is a temporary diversion. However, we do see loop stomas done for permanent ostomy diversions as well.
Okay, let's get out of this. Let's go forward. Forward. Click. Move ahead. Okay, 1 second. Hang on with me. Uh-oh. No. Go away. How do I move ahead? Okay. Ileostomy overview. Okay, I can do this. I know I can. Sorry. Okay. No. No, 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 no. Oh, goodness. Okay. All right. We're good? Are we all good?
Yes.
Okay, thank you.
Yep, we're seeing it.
Thank you. Thank you. Okay. So an ileostomy is typically located in the right lower quadrant of the abdomen. The effluent or drainage or stool is semi-liquid, very liquidy, paste-like consistency, and it's going to be soft because there's been no absorption of the food and the water in the chewed up stool. Okay, so now we're going to talk about the continent ileostomy. So a Coke pouch, it is called a Coke pouch. I think Dr. Don called it a couch pouch, which is pretty funny. He is a great doc. I think he got a little mixed up, but the right lower abdomen, just above the pubic hairline, it's very low and it doesn't look like a usual stoma. And that is because that stoma is created from the ileocecal valve that keeps it closed. So it's only going to drain when the patient puts a tube into it, and that effluent is going to be liquid. So this was all, I believe, in chapter 4 of your online course before this class. So it's important that you understand that. So you can see they made a new pouch and they bring that opening to the skin level. We do not see this very often anymore. There are other types of continent pouches that we're going to show you now. No, I went the wrong way. So what happened? Okay. I'm really having a hard time with this. I'm so sorry. So this is the urostomy. No. Let's go to the urostomy. Did I skip something, Joy? Okay. The urostomy, also known as an ileal conduit, is also located on the right lower side of the abdomen. And frequently the fresh new urostomy will have stents in it. And it is an end stoma. It's usually red and moist. Sometimes it's a little less red than the fecal ostomies. A ureterostomy is when they bring the ureters out to the abdomen, one on the right side, one on the left side, or sometimes maybe just one. And these are not typical stomas either, okay, because this is the opening from the ureter, which is quite small, and these can be difficult to pouch. Again, it's not your typical stoma. They're not using the lining from the intestines to make that stoma. It's very, very different. Again, not something we see very often at all. Continent urinary diversion is the Indiana pouch. And as you learned in chapter 4, this is where they actually remove the bladder and create a new bladder from intestines. And then they bring the diversion up through the umbilicus, which is kind of funny to have to intubate your belly button, or through an opening on the abdomen. So that's pretty amazing. And then they would empty that on a regular basis. The Mitrophanoff is done mostly with children, and this stoma is on the right side of the abdomen and also is not your typical stoma because it is directly from the bladder pouch, the new bladder pouch, right out onto the skin surface. And this is continent also because I believe there is, we're using the ileocecal valve. So you can see here the diagram of two different types of continent urinary diversions. You have the traditional ileal conduit on the left, where they take a segment of the small intestines and they bring that out to the abdomen, or you have also a continent reservoir where they can also remake a whole new bladder and then connect it to the urethra, and that person would void in the typical manner. Well, albeit a little bit different because that new bladder is in a muscle. So sometimes they have to strain or do more of a Valsalva maneuver to empty that pouch, to completely empty of urine. Where the ileal conduit is constantly urinating because the kidneys are constantly making urine. So it tends to keep on dribbling all day long. So the location of the stomas is either the right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, just like you do bowel sounds. And we like this stoma to be within the rectus abdominis muscle. When we assess location, we want to notice where it is. We're going to look for the skin folds. Notice any skin folds. Where is their belt line? If there are any bony prominences. And you can see by the diagram below of different sizes of people. And you can imagine the person, the 3 or 4 to the left might have difficulty observing that stoma when it's in the lower part of the belly. They can't see under there, and many of them have trouble even reaching that area. So quick questions. Can you describe an Indiana pouch? What is that going to be? Please type in your answers. Is it a continent fecal diversion, incontinent diversion, continent urinary, incontinent urinary? Okay, you're saying continent urinary. Okay. Why my clickers don't want to work is beyond me. Okay, it is a continent urinary diversion. And I do want to mention, as Dr. Don did, this is a very, very big surgery. It usually takes almost 8 hours. It's quite extensive, usually done on younger people. So what type of diversion am I? I'm located in the right lower quadrant of the abdomen, and my effluent is semi-liquid to soft, semi-fluid, pasty-like consistency. Am I a colostomy? Iliac conduit, IPAA, ileostomy. Okay. It is an ileostomy. Okay, that is D. Okay, so remember, it's the right lower quadrant. Colostomies are on the left side. Okay, ileostomies, 99% of the time, I want to say about, are on the right side. Occasionally you'll get one on the left, but very, very rarely. Okay, so, temporary or permanent? That is the question, okay? And this also has a lot to do with patient acceptance that Joy talked about earlier. Really, patients with temporary stomas tend to be less accepting. Usually they would go in with a bellyache and wake up with an ostomy from diverticulitis or ischemic bowel. And they're quite in shock and having a very, very hard time accepting that. Permanent ostomy, the patient usually has a little more time and had a little more education about what's going to happen and can mentally prepare themselves. So stoma construction. An end stoma, as I said earlier, is a stoma that only has one opening, one lumen or os, the mouth. And you can see on the top picture, very easy to see. And again, this is created from one part of the bowel. The other part of the bowel is usually sewn shut. It definitely is sewn shut. You can't leave it open. You'll have peritonitis. Okay. The loop stoma is a stoma with two openings, and it discharges from both ends. So one end will produce stool, the other end produces mucus. So we call that the proximal and distal stoma. And frequently, surgeons will place a rod underneath that loop and to stabilize that. And they used to say to prevent it from being sucked in, but you'll often notice lots of loop stomas are created temporarily, especially in your J pouch, your ilioanal anastomosis surgeries, because then it will be taken down and reconnected to go to the J pouch. So you can see the two openings, and this is usually done by, you have the intestines all together, and then the doctor brings it up and he just snips off the top, and now you have an opening going to your mouth and you have an opening going to your anus. So the one to my mouth is where the stool is going to come out, and the one from my anus is just going to keep making mucus, because that intestinal lining doesn't know that it's not making any more poop anymore, and those mucus cells just keep making mucus, and it's got to go somewhere. So it'll come out the stoma, and people will also have mucus coming from their rectum as well. And that's something they all need to be educated about as well, and can be very disturbing. The double barrel stoma is, again, two distinct stomas that are brought up either right next to each other. Typically, they are separated as in the picture below. And again, one makes mucus, one makes stool. And if they are very close to each other, obviously, like in the first one, you're just going to pouch that all together. On the bottom one, they are very close together, so that may be difficult to pouch. But we will show you techniques later on to show you how to manage that. So rods and stents, I just talked very briefly about rods, but your ostomies or your ileal conduits generally come out with stents. Now these are fairly large. Typically they look like wires, and they are going into the ureters, and they help protect the anastomosis and keep those ureters open and patent. And they usually come out in 7 to 14 days. Sometimes they even fall out on their own, and nothing to be concerned about, but patients do get a little disturbed when they see wires coming out of themselves, just like anyone else, and that is where the urine will be coming out. Here are some photos of the rods. There are two different types. You have the butterfly-shaped bridge, and that folds in half along a hinge, and that is usually placed underneath the stoma and sutured down. The same thing with the L-shaped rod. This one also holds the loop of bowel above the skin. Some surgeons also will use just your skin to be that human rod, shall we say. So I'm seeing less and less of these, but there are some surgeons, your old timies, that love this and they continue to use them. So you can see here this fairly large stoma with the L rod underneath, and these can be quite the booger. When they're post-op, they're very swollen, and they can cause pressure injuries and wounds underneath the rods, and very challenging to pouch over these rods. And again, we will talk about that later. And your butter-shaped bridge is another one, and you can see it's sutured down. And you know, to pouch an ostomy, you need a flat playing surface, and this is not by any means flat when you have plastic objects under there. So we would have to use lots of caulking and whatnot. Then the other type of rod is a red rubber tubing that we also know as the Red Robin catheter, that the doctors just cut and they put it underneath, suture it down, and they use this to hold the stoma in place as well. These, I don't know, a little more forgiving. This might be in a facility where they don't purchase those rods and they makeshift, and these are wonderful. They work great. They're very easy to remove, and we will be teaching you also how to remove the rods as well. Are you excited? That's kind of a fun thing. A little more advanced in taking out sutures. Okay. So it should slide easily back and forth if it's not sutured down. Here you can see they were able to get a barrier underneath the rod, and that's beautiful. That's a great thing. But again, those rods can cause trauma and ischemia and like deep tissue injuries. Usually removed again in 7 to 14 days. You're probably wondering how in the world did they get that barrier underneath? Well, they cut the opening and then they cut a hole. They basically will, if say this is the barrier, they're gonna just cut straight through here and then open it up and put it around. Not sure if I could show you that very well there. But they cut it. That's basically it. And again, these are your more typical stents that are in place. These are very small, fine bore, and inserted during surgery to prevent stenosis, as I had said earlier. And sometimes they do just come out on their own. It's not a cause for alarm. Just notify the surgeon. And I've never seen them put them back. Let's put it that way. So yeah, very, that's it. That's what they look like, wires coming out of the stoma. And that is a barrier ring that is placed around that stoma, you see. The stoma lumen, again, this is the mouth. I call it the mouth of the stoma or the os, and that's where the effluent comes out. And we like it to be at the top of the stoma. It makes for a nice spout. Sometimes the lumen is on the side or level with the skin. And as you can see in the bottom left, it's hard to see, but that os is just a little, it's pointing sideways. The one on the right is pointing upwards. And the one on the top right, I'm not sure where it is, but I'm thinking it's in the middle. And when the os, the lumen is on the side, it does make it a little more challenging to pouch. And again, more tips for later. And we're going to use the clock method to document where the lumen is. So here you can say this lumen is at 6 o'clock. And again, same as with wounds, your head is at 12 o'clock, your feet are at 6 o'clock. The mucosal color should be red or dark pink is healthy. We want it to be red or pink. If it's pale pink, and usually, as I said earlier, a urinary stoma can be a little paler. But if you have a fecal stoma that's pale, I always think they're anemic, And generally, if we do lab testings, it will show that they are anemic. And so that's a key. It's just like your gums. When you think about it, it's the same tissue from your gums to your anus, and that's what's protruding out of your belly now. So if the color is dark reddish purple, as you can see in the top photo where the arrow is, it's a little darkened. That may be from bruising. Okay, I have seen bruised stomas. Just keep monitoring it and it should resolve. Now, if it's black, purple, blue, that's from ischemia. That's a lack of blood supply. If you were to touch this stoma on the bottom right, it would feel very mushy and boggy. And that would be a necrotic stoma. I hope you don't see many of those. Again, here is that necrotic stoma on the right. Due to lack of blood supply, something happened during the surgical procedure, and that stoma is not viable. The stoma on the left has a brown little hat on it, and this is called melanosis coli, and this is caused by excess use of laxatives. And again, this just makes this lack of blood supply on the top, but it's okay. It's not dead. Sometimes these things slough off in the beginning. You might see a stoma with a little brown cap and it sloughs off. The melanosis coli is always going to stay like that until unless maybe they stop taking the laxatives. I personally have never seen this, but I have seen necrotic stomas. Not nice. And in the hospital, when I was taught at MD Anderson, we would actually, and you might see your surgeons do this, take a test tube, insert the test tube into the stoma and shine a flashlight in it to see if it's necrotic deeper below. And that usually helps them determine whether they need to do a revision or if it will be viable. So the mucosa appearance, again, in the beginning, it's going to be edematous, shiny, and taut. And then it will shrink over 6 to 8 weeks. But the mucosa should always be moist. If it's dry, they're dehydrated, something's going on. But it should always be moist and red. It's edematous in the beginning, especially immediately post-op. You will see this where it's quite swollen. And again, it gradually decreases over 6 to 8 weeks. I always tell people it takes 6 to 8 weeks for the stoma to assume its rightful size and shape. And usually after that, it stays that way for a very long time, unless the patient gains or loses a significant amount of weight. The stomas will change. Again, if the stoma is dry, there's my alarm. I guess we're getting towards break time. Let me just finish up this little section here. Again, same thing. Is the stoma, is the mucus, is it dry or moist? Again, it should always be moist. I have very rarely seen a dry stoma. And are there grooves? Are there creases? Does it look like a rosebud? This one on the top right is definitely bizarro. I haven't ever seen a stoma like that. And the one on the bottom is also, I think the mouth is at 3 o'clock. You can see it there. And the mucocutaneous separation, it's not separated, but it is bizarre. It's different. So you would mark the epithelial surrounding. Oh, let's just watch this little video and then we'll,
Actually, I sent them the videos. It might be better for them because the videos are not coming over very well.
okay. So why don't we take a break now then? And you can watch this video on why stoma sizes vary, and then we'll come back in 15. How's that?
I'll set the timer for you.
Okay. All right, Carissa and Jennifer, see you in 15. WOCN, it's crazy, but wound care specialist. Why did Carissa leave? Did we lose her? All right. Okay. All right. Good, Carissa. I'm glad you're here. So sometimes the stoma is a highly vascularized piece of intestines. It's very fragile and it will bleed. And sometimes it bleeds during routine cleaning. And patients freak out at this. They really do. So it's really important to let them know the stoma will bleed when you're cleaning it. And honestly, lots of times I tell them, you really don't need to clean the stoma. It's self-cleaning. It's the inside of your intestines. It's used to having stool on it. But people want it to be just right. And just know, if you're cleaning it with a washcloth and you rub it a little too much, it's going to bleed. Okay? So it usually stops. Just apply a little pressure and it stops. Now, blood coming out of the mouth of the stoma is a horse of a different color. That's a cause for alarm. But bleeding of the stoma, happens all the time. Okay. This is a nightmare. This is not good. Something's happened here. You have a huge mucocutaneous separation. You have, looks like a catheter in there, and you need to notify the surgeon immediately. This is not a good situation. I'm sure you all are aware of that. So, lacerated stoma. This can happen if they're cutting the appliance too small, or they rub the wafer up next to the stoma, can cause a laceration. And again, apply pressure and it should stop and it should heal very quickly on its own. And again, should be moist. Now the stoma on the bottom, you see has what is really kind of a hypergranulation or granulomas, these little pimples. These are called granulomas, and these frequently occur from moisture, and we're going to talk about how to treat those at another time, but they do tend to be sensitive. I'm working with a patient right now, and she says it hurts. She says that stoma hurts. The little pimple, the granuloma. Generally, as a rule, stomas don't have any nerve endings, and people are not able to feel them. There is that 10% though that do say they feel it. So we need to acknowledge that and move on. Just know most people can't feel their stomas. And again, we're assessing for changes in color, and necrosis is not the good one that we're looking for. It does happen if it's getting dusky, it's getting gray, the tissue is loose and flabby. Again, if you were to touch this, it would just, it would be kind of gooey and not viable. Again, need to notify the physician immediately, the surgeon, and varices. Stomal varices, we don't see on the stoma itself. This is, you're going to see these little purple hairy discolorations around the edge. Those are very, very tiny capillaries on both of these, and that is caused by venous portal vein hypertension. We also call this caput medusa, which is strange. But it's like, the Medusa with all the snakes coming out of its head. That's what it kind of looks like, all these little, capillaries just pruning out, spitting out there. So let's go over stomal shape. Again, we said the ideal one was perfectly round and protruding and red and moist. But sometimes they come out oval, or sometimes they're just irregular, and everybody's stoma is different, just like your nose is different. Not everybody has a perfect nose, and there is no such thing as a perfect nose. So the protrusion is really important for proper drainage. In the old days, the doctors thought they liked it to be flush because of appearance sake, but we now realize that we need for the stoma to protrude to have better pouching appliance systems for it to be able to catch the stool. Because when the stoma is flush, the stool wants to just run off down into the skin. And when it protrudes, and I have an example here, the stool is going to shoot out, as opposed to going down. Can you see that? Okay. And this stoma varies in length, and generally, as a rule, they should be about 2 to 3 centimeters in height. And I have a little measuring guide here. So this one is 3 centimeters high. So you can see that. And you will see them move sometimes. And that is actually peristalsis in motion, which is really cool and can also freak your patients out too. But it does happen. And so we need to educate them because, again, they've never had a stoma before. They don't know what to expect. They don't know what it is. So even just the littlest things, I always say there's no stupid question. And these people who have ostomies have maybe never known anybody with an ostomy or heard of what an ostomy is. So they are in quite the scared. They're usually very scared. Okay, so here you have some examples of a flush stoma, and it's at the skin level. Or it could be retracted, meaning it's even sinking in. So these are more challenging to pouch, and we will be going over that later. And again, we want it to protrude moderately, 1 to 3 centimeters. Greater than 3 centimeters, then we start getting into a little bit of a risk for injury, and that's mostly from pouching, or if it's prolapsed is a horse of another color, and we will talk about that later. But for the most part, most of them stick out up to 3 centimeters, and that's great. And here you have the one that's prolapsed. Okay, so when it prolapses, it's basically telescoping away from the abdominal surface. So what happens is, think of a telescope, it's small and then, and that's what happens with the intestines. They just kind of protruding out. And again, this is most common on your transverse stomas. You will also see these on babies quite a bit, and challenging to pouch and very offensive. A lot of people say it looks like I have a penis hanging out of my belly, and particularly women find it very offensive. But again, you would just handle this very gently with gloves on, and usually we pouch this with a one-piece appliance, so there's no chance of clicking onto the stoma. And again, we're going to talk about pouching this later. Pretty groovy, huh? Ooh. Okay, so quick questions. Okay, get on your chat box. This benign condition causes color changes to the stoma and is caused from excessive use of laxatives containing cascara. I am. What is this condition called? C, correct. Melanosis coli, very good. Next, what is the recommended treatment for melanosis coli? Is there any treatment? Right, there is no treatment. You just leave it alone. They're basically stained. Okay, so stoma size. As we said, stoma sizes vary. Ileostomies tend to be smaller, colostomies tend to be larger. And you just never know. Okay. Um, I actually had one of the biggest stomas on an 8-year-old boy. It was like a cinnamon bun. It was huge. Poor thing. But he had Hirschsprung's disease, and we'll talk about that later as well, which is another disease of the GI tract. And his stoma was huge. And then you find really big people have little stomas. So there really is just no really rhyme or reason. I'm sure there is. It depends on the size of their intestines is going to be what the stoma is. Okay. All right. Move. Okay. So loop stomas obviously are larger because it's 2 stomas instead of 1. Okay. The loops are constructed, as you can see in the picture. They bring the intestines out, they bring it up, they cut off the top, and now I have 2 openings. Okay. The ureterostomies, as I said earlier, tiny, tiny stomas. It's, a piece of the ureters, and ileal conduits tend to be smaller. I find most of my ileal conduits are 1 inch or 1 1/8 inch. Perfect. Excuse me. So, to measure the stoma, we have stoma guides. And here is one from Convatec. See, Convatec. And this is the size of the kid's stoma. It was enormous, okay? And I have seen little tiny stomas like this too. Okay. Most of them tend to be around this size. Okay. And so I have a little stoma here. I'm going to show you. So you want it to fit just juice to juice. I say within about 1/8 of an inch or less around the stoma. So I could say that's too big. You don't want it that size. That's too small. That's too small. Woo! I lost my stoma. Woo! And I think, how funny. That one could be too small. It's about going to be the size, which is 1 1/4 inch. Okay, so you would cut your pouch to 1 1/4. Hope you could see that. My clicker not wanting to go. And then the height, the stoma size measurement. Oh, again, if you have an irregular shaped stoma, you measure at the base of the mucosa to the mucosa. Okay, so here I'm going to go back previous. I have a loop stoma that I made. Okay, and I just want to show you how generally you're going to measure this height by the length by the width. And with this one, I'm going to say, okay, this stoma, really to give me an eyeball, it's going to be about 2 inches. Okay. And here on the next page, we always document in millimeters or inches, and that's so that's the sizing of the ostomy appliances. I tend to use inches. In Europe, they tend to use more of the millimeters. It really doesn't matter because as you see on the guides, it has both. I can't really see you, so I hope that's good on the measuring guides. And for the loops, you're going to measure using the guide or other diameter measurements. So I can say this stoma is 3 centimeters high by 5 centimeters wide. Okay. So in your cut to fit ostomy supplies, you'll always get one of these measuring guides. This is the one by Hollister. Okay. And again, you're going to use that to determine the size of the barrier. Okay. And again, like I just said, you don't want it too big. You don't want it too small. You can make a drawing, and I'm going to show you how to do that in a second. Similar to using, this is the back of the appliance that she's putting on there. And to do a tracing, so what I've done with my oval stoma is I took a piece of plastic and I drew it over my stoma, as you can see there. Then I cut it out. Can you see that? And I just gently place it over to make sure it fits. Okay, look, it fits good. It's a very good fit. And then what I would do is draw it on the back of a wafer. Okay, either like this. Some of these old styles do not come with any guide on the back, so you would have to draw it on. And with that, I use marker, like so, and just and there, I've drawn it on with my marker. And you could save this as a template, or I could put it on a one piece. And here, Coloplast has all these, and this just fits. Okay, you don't want to go outside the blue lines. They do make bigger pouching systems, but you would do the same thing. Draw it, because you don't want too much skin showing. So here you go. And you need to make sure you get it the right way, because if I drew this the wrong way, I'd be putting it on like that, not like that. So that's where you get your inside out and lefts and rights mixed up. And it happens to the best of us. So just, if you made a mistake, do it again. And here again, showing the tracing. And it is good to put the head and the foot on the tracing. So that's pictures of basically what I showed you. I don't know, better or worse, because I can't see myself. Okay. And again, you're going to use the clock method to determine, where the opening is, where there are any complications, and the height. Again, you can measure the height. Really, the height becomes more of a problem when it's, less than 1 centimeter or flush, or if it's, 8 centimeters long. Really, the effluent, the amount of output, okay? When you have a new ileostomy patient, it's really important to measure their output. If somebody's putting out more than 1,200 cc's, that's a high alarm for dehydration, and they need to be rehydrated. They need to be drinking lots of Gatorade mixed with water. Actually, water is not the best solution for high output. If they're in the hospital, they're going to be on IVs, but when they go home at first, they need to monitor how much output they have, just to keep track. Ileostomates will empty probably 4 to 6 times a day, sometimes 8 times a day, depending on how full it is. We always say empty it when it's about 1/3 to 1/2 full. Colostomates will empty maybe twice a day. But if they're emptying, when I ask a patient how many times a day do you empty, if they tell me 20, we got a problem. Okay, we need to look into what's going on. And we will, again, talk about that later. So immediately post-op colostomy, they're going to have some serosanguinous drainage, okay? It may take as long as 72 hours, 3 days before we see anything. And in the beginning, what we're looking for actually before we see stool is going to be gas, because that's the first sign that the bowels are functioning. So formed stool takes much longer to happen. But again, we're going to see in the beginning some serosanguinous drainage and gas. And that's why in the hospital, we don't usually apply pouches with filters, because the gas is a positive sign. Post-op ileostomy, the output is usually 12 to 24 hours, and it's dark green, it's viscous. Interestingly, ileostomy stool, it doesn't smell. It really doesn't have much odor at all, if any. And that output will thicken as food intake increases, but it can be quite green, dark brown, golden. Okay, where the stomal effluent tends to get more thick, pasty, oily, thin. In the beginning, it's not unusual to have some blood in the pouch, some blood in the stool in the very beginning. And the fecal odor, it is present. It can be strong, can be foul, can be pungent, musty, sweet. I told you in the hospital, when I worked at Baylor, I worked at a VA hospital, I worked at KU, I can smell cancer. When the patient has cancer, I can smell it in the stool. It's very strange. But, and again, the flatus, the gas, okay, the first signs of bowel starting to function again. There you go. Farting out of the stoma. And that is a big aha moment for patients too, because they didn't realize that they weren't going to be poofing anymore from their rectum. And some of your guys, they might miss that a little bit. But they will be passing gas through their stoma, and that can be problematic for a lot of people. I hear other people, grandparents saying, my grandkids love it when it does that. They just giggle and laugh, but anyway, again, that's what you're looking for that bag to blow up, and they need to pay attention to that bag when they first are in the hospital. They need to mind the pouch. And again, large, moderate, minimal. Some people pass 13 to 21 times a day. I think my roommate does that. And if it's perceived as excessive, they need to keep a diary. It's like anything. Patient tells you, well, it's a lot. Well, what is a lot? It's a very subjective number. Can you please keep a diary and tell me how many times a day? And that's how you can get some numbers. And I teach my patient that a lot. A lot. Quick question. Why are measurements of the stoma taken frequently during the first 6 to 8 weeks post-op? BBB. BBB. Yes. Whoa. The stoma is going to change for the first 6 to 8 weeks. Okay. Let's talk about urinary post-op. Again, going to have some bloody dark tinged urine there, and mucus threads. Why are we going to have mucus? Mucus because we got a new piece of intestine in there that doesn't know what it's doing, and it's just making more and more mucus while it's getting adjusted. Again, it can be gritty crystals, cloudy, mucus, straw. Generally, we want it to get more yellow like normal urine. Sometimes there can be an odor, and again, that's going to be one of the ways we're going to detect a urinary tract infection. Again, assessment. Use your nose and touch, palpation, looking, okay? Cloudy urine always makes me nervous for a UTI as well. Crystals can sometimes happen, mucus generally always, and sometimes if it's more mucus than usual, again, start thinking infection. Stoma's functional status, whether it's not functioning, not passing, flatus or stool. This is a double barrel that they've created and very pale in color. I'm thinking this person is anemic. Why it would be non-functioning, perhaps patients at the end of life, perhaps there's a blockage. Again, you have to do a thorough assessment. You can't just look at the stoma and say, oh, he's got this. You have to do a more in-depth assessment. It's like you treat the wound, you treat just not the hole in the patient, it's the whole patient. And here the same with an ostomy, it's just not the holes in the patient, it's the whole patient. That mucocutaneous junction, okay, that is that line from that the stoma is attached to, where the doctor cuts that hole in the belly, brings up that intestines, flips it over, it's called a Brooks procedure, and sews it down. And occasionally that cut line becomes separated from the stoma. And this is something you're going to look for immediately post-op, and you would treat this wound the same way you would treat a usual wound. You're going to maybe fill it or use stoma powder, but you need to that is one of the first things you're going to document when you're in the hospital. Is that mucocutaneous junction intact or is it separated? And we're going to go over treating that more later as well. A lot of stitches there. Here you can see beautifully attached, very nice, normal appearance. It epithelializes there and it's free of tension or infection. And here you can see it is separated. Don't mind my pink nails there and tissues, honey. I don't know what's going on there. And you want to measure the width and depth and use the clock method. You might say this is mucocutaneous separation from 6 to 8 o'clock, measures about 1 centimeter, yellow base. I would tend to fill this with stoma powder and cover it with a hydrocolloid and then pouch. We'll talk about that again later. Okay. So here, or you could also use a percentage, 10% mucocutaneous separation. You got to make sure you can say that, mucocutaneous. Can you say that? Mucocutaneous separation. Okay. Try to be specific. Again, mark where it is, 6 to 8 o'clock. You want to know where that separation is and how deep it is. Sometimes these separations go very deep. This one is very shallow. Okay, so here are some more notes on the separation. Okay. The peristomal plane, that's the area that the 2 to 3 inches around the stoma that we want to assess. Basically, this is my pouching surface. And ideally, we like this to be flat. And I have to tell you this, most people, when they're laying down, it's flat. It's always flat when you're laying down, most people. It's when they sit up that you see creases. And that is a very important part of your assessment. Again, is that skin healthy? It should be the same color as all the rest of your skin, like this beautiful girl here. Should be no different from the adjacent skin. And then, you know, we do have people who do have problems. As you can see, this erythema, is it bruised? Is it staining? Is it dusky? The person on the bottom has the caput medusa, the varices, and peristomal skin dermatitis. The one on the top looks like could be allergic reaction to the tape because all around the stoma looks like it's fairly pink. And again, I'm going to go over peristomal skin complications tomorrow. It's my specialty. And we'll get into that in more depth. Again, the skin integrity. Joy refers to this as the ring of fire. That skin is all denuded, I want to say from 12 o'clock to 9 o'clock. And that burns like all get out. That is a superficial wound. And as we remember in our wound care class, the superficial is the most painful. It's similar to a second-degree burn. Again, any lesions, ulcerations, incisions, and scars, again, make note, document, document, document. What is this peristomal skin texture like? Is it moist? Is it crusty? Is it warm? Is it weepy? Weepy is where we come in and try to teach that patient how to manage that peristomal skin, how to heal that peristomal skin, and reassure them, this too shall pass. We will get through this. The peristomal skin turgor. What is the skin like around their belly? This woman got a lot of creases. She got fluffy belly and it all folding down. So this is a patient who we're gonna need firm convex belt to keep this pouch in place. Are they edematous? Is there any induration? Again, you got to see the patient sitting up. I found in the hospital, you'd put the pouch on, it'd be great. I'd get a call a couple hours later, pouch is leaking all over the place. What happened in between when I was there and 4 hours later? You know what? They got up and sat in the chair. And when they sat in the chair, all the creases occurred and the pouch popped off. Contact dermatitis, allergic dermatitis, candidiasis, folliculitis. These are all peristomal skin complications we're going to go over in depth tomorrow. And again, the majority of them easily treated, easily cured. And do stomas feel pain? And I believe I said this earlier, stomas don't feel pain. But there are a few that will tell you it does. But there are no sensory nerve endings in the stoma. So they really cannot feel pain from the stoma, but they do feel it from the surrounding skin. And that includes the granulomas, which usually are on the surrounding skin. And so hence, they probably feel that the whole thing hurts if their skin is irritated and painful. So let's talk about pain. The PQRST, you all know this from basic nursing, so this is just a quick review. What provokes or precipitates the pain? What causes the pain? What makes it better? What makes it worse? You touch it and it hurts. The quality of the pain, what does it feel like? Is it sharp, stabbing, burning, crushing? Majority of the time, your patients are going to say it burns, it itches, it stings. And does it radiate? Does it go from one area to another? What does it go anywhere else? With ostomies, not usually. And the severity, how severe is that pain on a scale of 1 to 10? We know 1 is no pain, 0 is no pain, 10 is the worst pain in the world. T for time, when did the pain start, and how long does it last? And again, your pain assessment, the 5th vital sign, you're going to take your vitals, and then you're going to do your pain assessment. Verbal response, nonverbal, pain history, pain goals. You're going to do the subjective response, and you're going to do an objective response as well. I know so many of my patients, they say this, the pain is a 9 or a 10, and they're sitting there and they're smiling, talking to me. So my objective assessment is it's not so bad. But I do acknowledge what they say, And in my documentation in home care, they do want subjective and objective. What did the patient say the pain was? Do I show any signs? Are they grimacing? Are they crying? You know, or are they smiling? You know these patients. And then we have the Wong-Baker faces to help us with patients who are nonverbal or even, you know, a lot of people don't want to say they have pain. Maybe they have discomfort. And is it in their language? Escala de dolor. Do you have dolor? Es más, es menos. Okay. And a thorough assessment is basically the foundation of ostomy care and management. This is so important. I can't express. We're going to do a little status check, and then I'm going to open it up to any questions. Okay. So what is not a purpose of conducting a stoma assessment? Okay. It is to assess the quality of the surgical procedure. Well, that's very interesting because really, we are not in a position to determine the quality of the surgical procedure. Okay, we would love to. I have, but I don't recommend you tell your surgeon they made a lousy stoma. Nobody wants to hear that. And in addition, you don't want to tell your patient you don't have a good stoma. Every stoma you look at, you're going to smile and say, "Oh, what a lovely stoma. Okay, your stoma looks great." What we want to do with the stoma assessment, we don't want to do is assess the quality of the surgical procedure. Yeah, it was the no question. So yeah, we can't do that. We want to, it's going to help us to identify complications, help in the product selection, and track any progress or deterioration. So in the immediate post-op period, a stoma assessment should be conducted how often? D. Carissa says D and Jennifer says D. Perfect. Every 4 hours in the first 24 hours. The ideal stoma is A. Moist, round, and beefy red. Nice. Okay. We want it sticking out more than 1 centimeter. The ideal stoma is located on the abdomen with what? B, 2 to 3 inches of flat surface surrounding the stoma. Excellent. What type of diversion am I? I'm located on the upper abdomen, either in the middle or toward the right side of the body. My effluent is a paste-like soft substance. Transverse colostomy. Excellent. What type of diversion am I? I am located low on the left side of the abdomen. My effluent is the most formed and solid. D, sigmoid colostomy. That's where all the liquid has been absorbed. And so now I'm going to have, you know, the closest thing to form stool and the poop I used to have as I did before. What type of diversion am I? I'm located on the right side of the abdomen. My effluent is high volume with a liquid mush consistency. Okay, the answer to this is the ascending colostomy. Okay, there is no such thing as a sigmoid ileostomy, the sigmoid colon, but no sigmoid ileostomy. Okay. Ileal conduits and continent urinary diversions are usually located in the right lower quadrant. Okay. Usually we don't put stomas in the upper quadrant unless they are obese and can't see it. Usually right lower quadrant, below the belt line, if possible. Okay. So not the upper quadrant. We tend to avoid that. In a double barrel stoma, the distal stoma will drain mucus. Right. Very good. In a loop stoma, the rod is usually removed 7 to 14 days post-op. Very good. Stomas are measured using either inches or millimeters. Why are these units of measure chosen? It is D, to match the sizing of the skin barriers. Yes, all the skin barriers come in millimeters and inches, and that's universal for Europe, Asia, here, everywhere. Your patient is 2 days post-op sigmoid colostomy surgery. There is no fecal drainage. However, a small amount of serosanguinous drainage is noted in the pouch. You should yes, continue to monitor, no action required. Can take up to 3 days to get that bowel moving. Okay, and sometimes people will get an ileus, which means the peristalsis hasn't started again. One of the things we used to teach our patients to do in the hospital then was to chew gum, and chewing gum helps get that bowel going, because remember, digestion starts in the mouth, and actually chewing stimulates the bowels to move. Initial post-op ileostomy effluent is what color is that ileostomy? B or D? I think it's B. Dark green, viscous, and odorless. Viscous is kind of pasty, oily. Your patient is a post-op urostomy. On the first day post-op, you note there is no urinary output in the collection pouch. What should you do? Hey, you want to notify that surgeon. It's like, hello, I have no pee, there's something wrong. And occasionally the stents do get blocked, and he may ask you to irrigate them with a tiny bit of saline. A stoma assessment should include peristomal skin turgor. Which statement is not descriptive of skin turgor? Which is not descriptive of skin turgor. It's D. Skin is red and crusty. You're right. Skin can be soft and flabby, can be indurated, can be edematous, can be firm. And the PQRS tool is used to assess for what? You all know this. Yeah. It's pain, PQRST, what provokes it, the quality. Okay, that's it. All right then. So I'm gonna give over my screen to Joy, or see what we're gonna do.
Yep, you can give it to me.
Do you need help to do that, Anita? Looks like you have it, Joy.
All right. Hey, there
There
we
you
go.
are.
Okay. All right, let me get my clicker in the right place. Thank you very much, Anita. Appreciate you taking us through that stoma assessment. Sorry about the videos. We just have a lot of internet traffic right now with kids out of school and having to do things online. And so you can see that Diana has emailed you links to those videos, and you can look at those later on. All right, now what we're going to get going with is stoma sighting. So section 11, and when we get through with this one, we will go to lunch. All right, first off, why do we do stoma sighting? The reason that we do stoma sighting is we're going to evaluate our patient's abdomen, and we're going to look for the best place on their abdomen for the pouch to go. We're looking for an area that the patient's going to be able to see, that the patient's going to be able to reach, and the one that is going to be the most appropriate for the pouch to be there. So what I'm talking about is a good peristomal plane. And as I get going into this, you'll see what I'm talking about. It makes up a good peristomal plane. Now, the reason is to reduce postoperative complications. That's why we do it. We do it to find the best location so that they have the best opportunity of this being a nice budded stoma. You know, if your stoma is budded, here's a budded stoma, as opposed to one, let's say that's going to be flat like that. If it's budded, it's sticking up off the skin surface. If it's budded, where's my pouching system? If it is a budded stoma, here we go. If it's a budded stoma, it protrudes into the pouch. So can you see it protruding into the pouch here? As it protrudes, it's going to drop the urine or the stool right down into the pouch. And that's so much better than it just being a little stoma that's back there that's oozing out effluent that's going to undermine up underneath the skin barrier. Some people call it the wafer, the skin barrier, the face plate, the base, face plate or base plate, goes by several different names. But the last thing we want is for the effluent to run up underneath it. Now, who supports stoma sighting? Well, everybody from the American Society of Colorectal Surgeons to the WOCN Society. They say that if we take an active role in this and inspect the person's abdominal contours and find this best location on the outside of their body for this stoma to be created in, then it's going to be a higher probability that it's going to end up in the right site. Now, what would be the alternative of not having stoma sighting? Well, that's of course just going into the OR with nobody assessing your abdomen prior to the surgery. At best, the surgeon would have them sit you up as much as possible on the OR table to see if they can find any contours. And we know that that is not the ideal situation because there's no way they're going to be able to sit somebody up as well as somebody could sit up by themselves and do those other twists that we're going to ask them to do. All patients should have their stoma site marked preoperatively by that educated, competent, experienced clinician. But even if we do this, it is going to be up to the surgeon to choose the ultimate placement. And that's because we're looking on the outside of the body. We can't see adhesions. We can't see scar tissue in there. So it may be that we have marked the best place on their abdomen, but once the surgeon gets in there, the surgeon finds adhesions or scar tissue and is just not able to go with that site that we chose. So we do want to make sure when we're telling the patient that we're marking this site for the surgeon to use, we want to make sure that we say the surgeon's going to have the ultimate choice here, because once the surgeon gets inside the body, they may encounter other factors that are going to not allow them to choose the one that we had chosen for them. And you do want to make sure that you say that. but actually twice I've had patients that have texted me right after surgery, or one of them had a family member text me to tell me that the surgeon put the stoma in the wrong spot. It wasn't where I had approved it for. And so sometimes people don't remember that. I'm sure I did tell the patient that, but for whatever reason, they didn't remember that part of it. Now, who can mark somebody for a stoma? Well, Joint Commission says that as long as the person is familiar with the patient, involved with the procedure, they can mark. And it is going to be up to your individual state board and your scope of practice. However, I am not familiar with a state in the United States where we can't cite somebody for a stoma. Nobody's ever brought one to my attention. Come on, key points. What are some key points we need to know when we're talking about stomatitis? Of course, this needs to be done preoperatively. We don't want to wait till the patient gets in the OR and have to do this, because finding the right site is going to be critical for this to be an optimally functioning stoma and optimal management of the stoma. We do have to know the type of surgery. I can't have the surgeon say, Joy, mark it on the right, mark it on the left. I need to hear the surgeon say, mark a colostomy and mark an ileostomy. Again, for me, the site that I'm choosing is a recommendation, and the surgeon, of course, is going to have the ultimate choice. The surgeon's the one doing the surgery. So as they say, the surgeon can make the final decision. We want it on the abdomen within the borders of the rectus muscle. Now, the rectus muscle is what makes up your six-pack, and the rectus muscle is going to act as a splint. As you can see, the rectus muscle runs down the front of the abdomen. Well, let's say that this is the rectus muscle. As we go through that rectus muscle with that piece of intestine, hopefully the rectus muscle is going to prevent hernia formation and going to help prevent prolapsing as well. So there is a reason that we are going to go through the rectus muscle. Of course, we want this on an area where there's no creases, scars, bony prominences. We don't want this right up underneath the patient's waistband or belt line. We want this on the summit of their infraumbilical fat mound. Now, to find your infraumbilical fat mound, reach down low, and you should be able to find an area right there, starting at your umbilicus. There's a little crease, and then down low by your pubic symphysis, you might have another little crease. Your infraumbilical fat mound is that little fat mound in between the two of them. And when we're talking about this fat mound, I can find mine very easily. Mine is, look at here, mine's right here. And you know what? I can gain weight, and I'm bigger all over, but my infraumbilical fat mound, it has that same round contour. And you know what else? I can lose weight, and I still have that umbilical fat mound. No matter how much weight I lose, I still have that little mound. And that's because that's one part of our body that doesn't change much. The infraumbilical fat mound does not change much when we gain weight or when we lose weight. Now, if I gain weight and lose weight, my stoma can change size and shape. Yeah, it can become more round. It could become more oval. Or as I just said, it could become more round with weight gain or weight loss. But that's the stoma I'm talking about. Your infraumbilical fat mound, that would be your peristomal plane. And luckily, as we gain weight and lose weight, the infraumbilical fat mound, it doesn't change that much. I do want to make sure I've got 2 to 3 inches of smooth surface around this area that I choose, because that's my peristomal plane. That's where my skin barrier is going to need to be able to stick to it. I need to make sure that I'm 2 to 3 inches from the surgical incision, and it's not there yet. So what some people do is take a cotton tipped applicator and lay it down on the person's abdomen where the incision is likely to be, just to kind of give them a frame of reference when they're choosing the site. And I've got to make sure that the site that I choose is within reach and within the visual field of my patient. I'm going to have the person get in several different positions. I'm going to have them lay down. I'm going to have them sit. I'm going to have them bend. I'm going to have them stand. And I am going to look at their abdominal contours not only while they're in the position, I'm going to be noticing their contours when they're going from one position to another. If you only have one position to be able to assess your patient in, usually it's the sitting position for the most accurate. As we look at this person while they're sitting down, look at the left-hand picture. You can see how you've got multiple wrinkles in the abdomen, but when they stand up, it kind of flattens out. Let's look at another abdomen. Now, this one, while they're laying down, you can see those 3 X's, but they stand up. I'm sorry, they sit up, and that center X, it just totally disappeared right there. Now with this one, they're standing. This woman has a very pendulous abdomen. When she sits down, she's just got a palm full of that abdomen. Other physical considerations. Is this a patient that has that pendulous abdomen? Is this somebody that has a lot of folds or wrinkles? Is this somebody that has a deep abdominal contour? What I'm trying to say is they've got a belly roll that hangs over really far, like this person right here. It's another way of saying it is that pendulous abdomen. As we look at this picture right here, we can see that they're having their stoma recited. Yeah, it's going to be moved up. My guess is, and if you look at it, the way that they're holding that person's abdominal contours, they're pulling it out a little bit. I bet if they let go, that skin barrier, stoma, probably the whole appliance just disappears right up underneath that skin fold. I had a patient who ended up with a stoma like that as well. She wasn't sighted prior to surgery. She had a stroke, so she only had use of one side. Her stoma was on her left side. She had use of her right side, and the stoma ended up under her abdominal contour, and she was in a wheelchair. Oh, and let me add on there, she weighed about 270 pounds. So very difficult to get to. Very, very, very difficult to get to. It made her stoma always up underneath those abdominal contours. And you know, it's not just that it's under contour, add the weight of that adipose tissue on top of it. It can be very difficult to manage these, very difficult, if not impossible, for a person to be able to change the pouch by themselves, making them dependent on other people. So that could be one reason that this person is having their stoma brought up to a higher area. And do you see how high up those 3 X's are that are marked right there on their abdomen? But that's what it's taking to get this up to an area where the person's going to be able to see it and reach it. And when you think about it, that long pendulous contour right there that the person has, it's not like your intestines are hanging down within that pendulous part of the adipose tissue that's hanging down. It's simply adipose tissue. Other considerations, you know, is there going to be another stoma? When we look at the bottom picture right here, the person already has one stoma and now they're being cited for another one. And they've got a large scar right in the middle. So we not only have to make sure that we're minding where that other stoma is located, we have to watch out for the scar too. Now you can notice that the picture on the right, the one that's on the top, notice that they've marked this on different horizontal planes. They've got a stoma that's down low on one side, and now they've been marked a little bit higher on the other side. Whenever you do mark and the person already has a stoma, you want to make sure that it's on different horizontal planes, separated by at least an inch. The reason that you do that is it'll allow that person to be able to wear that little 1-inch manufacturer's belt to help, you know, hold that pouching system on. So that's why you want different horizontal planes, making sure that you're watching out for any scars or incisions that are already on the person's body. This is a beautiful stoma. Anita pointed out that a few minutes ago. But for this one, it's too close to that incision line. So that's a bad placement right there. Other physical considerations, you know, do they have any bony prominences that are right there in the way, such as their iliac crest? Does the person wear some type of brace to help them walk? If they do, I need them to have that brace with them when I cite their stoma. Is this a woman with pendulous breast, like in the top photo? And notice that they're marking for her pouch to be kind of right up here in the middle of them. So her breasts hang down really long. I hate to say long, but that's what they do. They hang down really long. And if it wasn't for putting the stoma kind of in the middle of this person's abdomen, it would be up underneath the person's breast. So maybe she just said, you know, I'd rather have it in the center than right up underneath my bosom. You never know. You never know. You also have to consider if the person has a hernia already. You know, what's their body type? Are they really thin? Are they really large? And we have to take skin turgor into consideration too. Yeah, look at this skin turgor right here. Other physical considerations, is the person able to see? What are their motor skills? Do they have pretty good coordination and dexterity to be able to work these appliances? Will they be the person changing out their own appliance, or because of some other issues, are they going to have a caregiver that's going to help them? With this guy right here, he's got the use of one arm. For him to be independent, I have got to make doggone sure he's going to be able to see and reach his stoma to keep him independent. And then it gets into other issues. You know, does the person have a history of radiation therapy? If they do have a history of radiation therapy, we don't want to site that stoma within that irradiated field. We don't want to do that. So that can make me tend to choose a different location. Now, when it comes to age, occupation, activity level, involvement in sports, that's not going to make me choose a different location for this person. As far as their occupation, if this is somebody who needs to wear their tool belt for work, I'm going to tell them, make sure that you bring your tool belt when I cite you. We will be sure that you're still able to wear that tool belt wherever we mark you. So it's very key that they bring that tool belt with them. And there are jobs that the job description says that they are going to be wearing that tool belt. So that can be a very big deal. Now, as far as the type of clothing the person usually wears, well, I certainly don't want the stoma to be under somebody's natural waist or their belt line, but I don't cite somebody just so they can wear a specific type of clothing. I would make sure if there was a uniform that the stoma wasn't in the way. But when it comes to specific types of clothing, I've seen hip huggers come and go 4 times in my lifetime alone. Other positioning considerations, if the person has contractures, again, let's be sure that we're keeping the person independent by making sure that they can see and reach their stoma. If this is somebody in a wheelchair, I'm going to mark them in the wheelchair if they're confined to it. And again, if they use a walker, I need them to have that walker with them when I'm marking them. If there's multiple stomas, again, we want to mark those on different horizontal planes. Different horizontal planes. Typically, a urostomy stoma is going to be sited higher than the fecal stoma. That's the typical way it's going to be done. Again, different horizontal planes separated by an inch to allow that person to be able to wear that ostomy belt. Now, there can be different religious or cultural considerations. As I said, some cultures use one hand for eating and the other hand for cleaning. Typically, the right hand is eating, left hand is usually going to be cleaning. You do want to make sure that you have good conversations with your patients, find out if they are within this faith, and make sure that their hands are able to access that stoma. It can make a difference, perhaps with the Islamic faith, if their stoma is sited above their umbilicus. Anything that comes out above the umbilicus is seen as clean output, and they could use either hand. But if their stoma is sited below the umbilicus, well, it's seen as waste, as fecal waste. And so, of course, they would be limited to one hand with that. We don't want anyone to have a leak in their house of worship. You know, no matter what your faith, I think we all agree that we don't want that to happen to anybody. So let's make sure that the person can get in their position of choice for worship. And if it's get in this position to pray, I want the person, when I'm stomaciding them, to get in that position, because I need to make sure that, you know, when you get in that position right there, you've got a lot of contours from bringing that leg up so close to the chest. You've got a lot of contours that your body's going to make right then. Make sure that there's not going to be any contours that develop that are going to cause a crease to develop that could ruin the person's seal on their pouching system. Quick question. When you're assessing the area around the stoma for appliance selection, what will you be looking for? So what is that peristomal plane that you're looking for? C. C is good. The skin 4 inches around the stoma while they're seated, while they're supine, while they're standing, looking for contours, scars, and medical devices. Very good, very good. Now, what equipment are you going to need to be doing this? Let's take a look. You're going to need a surgical marker. You're going to need a transparent adhesive dressing. That transparent adhesive dressing is going to be used to protect the marking, because sometimes we mark this person when it's a week or a week and a half prior to their surgery, and you don't want the marking to wash off. So typically we mark it, we cover it with the transparent adhesive dressing, and if it's going to be a week or more, I'm going to give them another dressing to put on if the first one comes off. I'm going to need me a flat skin barrier, and disposable measuring device and some alcohol pads. Now the alcohol pads are going to be, they aren't pictured on the screen, but they're going to be removed, they're going to be used to remove the lipids, the fats, or the oils off the person's skin. So let's see how we're going to do this actual procedure here. First thing that we're going to do is explain to the patient what they need to expect. We're going to tell them that we're going to have them get in multiple positions: sitting down, standing up, laying down, bending over. And I'm going to look at them in all these positions, and I'm going to look at them when they're going from one position to another. And I'm going to encourage this person to ask me any questions along the way. And if they've got any suggestions or any comments, please go ahead and make those comments. If they've got a friend or a family member that wants to stay in while I'm sighting them, as long as the patient's okay with it, I'm okay with it too. All right, now we're going to watch a short video. I'm going to hope that the connection's a little bit better right now, but we're going to watch another video on how to sight a stoma. Can y'all hear that? I couldn't hear that.
Oh, we couldn't hear that, Joy.
I couldn't hear that either. Let me try that again. What is the deal today?
What's the problem, Joy?
My sound. I'll get it. It's just my sound this time.
Oh, for your videos?
We've never had that before.
Click on the little microphone down on the bottom of the screen. See that little microphone at the bottom of the screen there, right next to the start and stop button? No, on the video.
Okay,
On the
let me
video
let me
screen.
let me move some stuff so I can get to it.
Yeah, click on that. It's unmuted. You've muted it. Now unmute. Yeah. And the volume's all the way up.
That mute, now it's muted. Yes.
That's okay. I'll go ahead and email those videos, Joy. I'm sorry.
Sorry about this, y'all. Folks, I'm sorry about this. That worked last week. Okay, I'm sorry about this, but that worked last week. Diana is going to email that to you. My apologies. We're just going to keep moving right on. Sorry about that. You can look at it during lunch if you would like to. So what are we going to do? We're first going to have that person get in the first position so we can have them sit down. We want them to sit down, feet on the floor, and we're going to look at them straight on. We're going to look at that abdomen. We're going to look and see if we see creases or scars. Is it symmetrical? Does this person have some type of brace that we need to work around, or do they already have a stoma? You know, a large scar that we've got to work around. I would note that at this time. Then the next thing that I'm going to do is go ahead and have the person get in that next position. So I can have them stand up or lie down or bend forward, whatever order I'm going to go in. As long as I go through all the different positions, again, looking at their abdomen in each position and looking as they're going from position to position. Looking for creases, scars, valleys, those abdominal contours, sometimes the ones that come and go. And hey, what's their skin turgor as well? We also have to consider what type of stoma are we going to be citing, because there are different locations where we're typically going to choose. Like the right upper quadrant, typically that's going to be your transverse stoma or your ascending colostomy. We don't see many ascending colostomies. The right lower quadrant, well, that could be an ileostomy or a urostomy. Left lower quadrant, those are my colostomies, descending or sigmoid. And the left upper quadrant, sometimes a transverse colostomy. A quick question. When dividing the abdomen into 4 quadrants during stoma sighting, what type of ostomy sighting will you be marking if you're sighting in the left lower quadrant? Left lower quadrant. Yes, descending or sigmoid colostomy. Very good, very good. All right, now as we're sighting, we want to identify the rectus muscle. As I said, this is also known as the 6-pack. It starts up here at the xiphoid process and goes all the way down to the symphysis pubis. And this is a really good location because, like I said, the rectus muscle is going to act as a splint and hopefully help protect this person, guard them against hernia formation or a prolapse. Now, it can be hard to find the rectus muscle on some people. If they can do a crunch. Yeah, that can help. If they can't put their arms back there, but just can raise it up, sometimes that can tense up the rectus muscle. Maybe if they just raise their arms up over their head and lift it a little bit, maybe that might help accentuate it. For me, if I cough, I can put my hands right here on my rectus muscle and cough, and that really, really firms mine up. So I can find my rectus muscle that way. You also want to go ahead and identify the infraumbilical roll or the infraumbilical fat band. It's easiest to find when the person's sitting down. Find that crease right there at the umbilicus and then just above the pubis, and it's the area right there in the middle. And like I said, this area rarely changes. Now, their stoma size can change. The stoma itself, yes, the stoma size can change, but the infraumbilical roll that rarely does change. Okay, it usually stays the same little mound. So what's the difference? Well, if my stoma size changed, if I got a pre-cut pouching system, I would need to change the order of that, change the size of that opening. However, with my infraumbilical fat mound, if that were to change, I would have to change out my whole system. So we're lucky the infraumbilical roll or the infraumbilical fat mound does not change. Boy, that would lead to leakage, issues out the wazoo. You can use something called the ostomy triangle as kind of reassurance that you're getting it within the right area, kind of is a visual guide for us. The points of the ostomy triangle are the umbilicus, the iliac crest, and the pubic symphysis. And I have seen this stoma triangle drawn a couple of different ways, such as the way these triangles are being drawn right here. And then I've also seen it drawn just as one triangle using the umbilicus out to the iliac crest and then down to the pubic symphysis. But it pretty much gives the same area anyway. Now, step 3, we're going to choose the site for the stoma. Again, we want this to be somewhere the patient can see. We want it to be somewhere the patient can reach. And we want it to be below the patient's belt line. The reason we want it below their belt line is so if they want to, they can tuck their pouch into their clothing to help conceal it. We got to make sure that we're going to mark this about 2 inches away from where we believe the surgical incision is going to be. And we want to mark it in an area where we know we're going to have 2 to 3 inches of space for our skin barrier. Step 4, we're going to do the marking. So we're going to clean that area with the alcohol pads. And when we clean with the alcohol pads, I mean, we're not cleaning off dirt here. We're cleaning off lipids, the oils off the patient's skin. And hopefully that's going to allow this marker to stay on the skin for a longer period of time. That's very beneficial when you're marking somebody and it's 2 weeks before their surgery or a week before their surgery. If I was marking them and surgery was tomorrow, it wouldn't be nearly as important. Okay, clean the area, use the surgical marker, apply the transparent dressing over it to protect it. Many times the surgeon's going to want you to mark 2 sites, and they want you to choose number 1 as your first choice, and then choose number 2 and label them number 1 and number 2 as your second choice. After you've done the marking, again, have the person get in all the different positions, standing, sitting, bending over, lying down, and have them make sure that they can still see the marking. And go ahead and make sure that they can still reach it as well. Number 6 is a final check. Apply the skin barrier right over the marking. And you can see that they've used a pretty generous size skin barrier. That's what you want to use. You don't want to go in there with your tiniest little skin barrier that you've got, something like this. Don't go in there with something tiny like this. Go ahead and carry a regular size and see the difference in these two. Yeah, so there is a difference here. Go ahead and carry a regular standard size barrier in there because you don't know what size the person is going to use. Put the skin barrier on right over the marking. And again, make sure you have the person get in all the same positions again to be sure this is the correct area. Now the person can gain weight after surgery. So again, go with that infraumbilical fat mound. Now it can be a problem when you've got that obese patient and you're not able to find the rectus muscle. And let's not even act like you're going to be able to find it. You won't be able to. So typically what we're going to have the patient do is sit up in front of us. We're going to note where their nipple line is and then kind of draw an invisible line coming straight down from their nipple line. And we want to mark it within the borders of that nipple line. Please make sure the patient's sitting up and not laying down, okay? That would displace those nipples. So sitting up and mark it within that nipple line. If the person uses a wheelchair, if they use a walker or some type of brace, again, they need to have it with them when you're marking them, so you can assure that this is going to, that this marking is still going to work when they've got that brace on, when they're using that walker, or whenever they're in that wheelchair. Quick question for you. Why is the infra-umbilical roll ideal for stoma site placement? Very good, yeah. The abdominal contour does not usually change with weight loss or weight gain with the infra-umbilical roll. Another quick question. Where would you choose the stoma site patient? Where would you choose the stoma site placement if your patient is obese? That's it. That's it. The upper quadrant, so they can see it, so they can reach it, so they can remain independent. That's right. Take your time when you're doing this. Really do. This is a benefit that you're offering your patient. Take your time. Don't rush through this. Remember, your whole purpose of doing it is for the person to have a good outcome. That's the whole reason you're doing it. It's for a better outcome for the patient, to find the best place that works for them. And then while you've got your time with them, do any pre-teaching that you can. Anita calls this prehabilitation. And that's what it is. Yeah. Teach them as much as you can prior to surgery. Okay. Do you have any questions before I move into the questions? And again, I'm sorry my video didn't work. All right. Preoperative stoma site marking has been shown to that's it. Decrease those post-op complications. That's why we do it. Whether or not you can conduct stoma site marking in your facility is governed by your state licensure practice act and your facility policy. That's it. That's it. And both of us can mark, whether we're OMS or WOCs, that's within my wheelhouse on both those certifications. We can both mark. And it's our state licensure practice act that tells us that. We do need to make sure that we have the approval of our facility. Okay, the surgeon writes an order for you to mark the stoma site preoperatively on a newly admitted patient. The most important information you need prior to doing this is what? Yeah, we've got to know the surgical procedure to be performed. That's it. The doctor can't say, go in there and mark it on the right or the left. I've got to hear colostomy, ileostomy, ileal conduit. I got to hear that. What's wrong with this stoma? It's a beautiful stoma. What's wrong with it? I know that there's not a fill in the blank, there's not a choice. Can you just, yes, look at you both at the same time. Too close to the incision. It sure is. What kind of stoma are you looking at right there? Is that a loop or an end stoma? What is it? A loop or an end? Yes, you're both right. An end stoma. Let me show you my little piece of intestine right here. An end stoma uses an end of the intestine, folded over and sutured down to the body. An end stoma. A loop stoma, they're pulling a loop of the intestine up onto the body. They typically use some type of stabilizer to hold it up in place. And then they're going to split that piece of intestine, open it up. And when they do, look at there, I've got two openings. I've got a proximal and a distal opening right here. Sometimes the loop stomas, you can see both openings. Sometimes you can only see one opening. And when you do, sometimes it's the distal stoma, so the mucus stoma. So that means the proximal one is hid. Sometimes you've got that surgeon that perfects the stoma, brings both ends of it out like this, and it looks like a little tube on the abdomen, or they put the two pieces, the two openings together like this. So loop stomas can appear several different ways. Most surgeons agree that the reason they like to do the loop stoma is when it comes time to take down, yeah, they just close it back up. And that's so much easier than, undoing this and doing that end-to-end anastomosis again. All right, too close. You want 2 to 3 inches, so you've got plenty of room to put that skin barrier. Your patient has a matured stoma from a colostomy, and you're asked to mark a site for a new urostomy. It's scheduled tomorrow. When selecting a site, you look for an area on a different horizontal plane. A different horizontal plane. Now, this is the horizon, horizontal. This is vertical. Right? On a different horizontal plane. When stoma site marking on an abdomen with multiple stomas, why use a site on a different horizontal plane? Yeah, leave room for that ostomy belt. And that's that little 1-inch manufacturer's belt. I'll show you one in a little bit. Okay, you're gathering your supplies before going in to site the stoma on a pre-op patient, which is not needed to perform this task. Ideally, yeah, a transparent pouch. And to be honest, I carry one in there with me because I always want to show the patient what they're going to wake up with. And when I show them that transparent pouch, I'm going to be showing them an opaque pouch as well. So yeah, I'm going to show them this pouch and I'm going to say, this is the pouch you're going to wake up with. It's a clear pouch. But later on, you can go to a pouch that you can't see through, one that's opaque. Because people are concerned about that. Okay, siting a stoma in the upper quadrant is usually done for upper quadrant, usually done for Carissa, was C your choice on this one? Did I miss you putting that one up there? I see Jennifer chose A. Did you choose C? Okay. Well, you know what? I like the obese patient. Yeah, that would be in an upper quadrant, but the descending colostomy, would that be an upper quadrant? Choose another one. Don't choose C or D. And don't choose B. So now choose another one. A, that's it. A is correct. That's it. A transverse or ascending colostomy. Now, an instoma or a sigmoid colostomy, sigmoid, we know that's lower. Obese patient, obese is higher, but that needs, descending colostomy would be lower. And ascending colostomy or instoma, no, A is a better answer. It's recommended that the stoma be sited within the abdominal region referred to by fitness advocates as the six-pack. This abdominal location is comprised of which muscles? Yes, the rectus abdominis. That's right. Now, another way to site the stoma is to keep it within the lines drawn by the ostomy triangle. Which point is not used to draw the ostomy triangle? That would be putting it way up there, wouldn't it? So yeah, we're going to ditch the xiphoid process. Very good, ladies. When marking a site for stoma location, the transparent adhesive dressing is used to, what do we need that for? Protection. Very good. Protect the sites after they're marked. Tell me if this is good or bad. Oh, it's bad. It is bad. It's bad. Yeah. It is bad. Yes, it's bad. And why? As Carissa said, it's in a skin fold. It is. It's in a skin fold. It's also really close to that incision. And you know what? I bet the person can't even see it. Look how it's tucked away in that skin fold right there. Yeah. So the person probably can't visualize it. All right. You know what? Before we go, let me go back to that video and just try one more thing. Unmuting on my computer. I'm just going to try it one more time, see if I can get it to play. Before we go to lunch, where's my video? Here we go. It is not doing it. It is not doing it. Okay, we will just look at that as Diana has emailed it to you. Okay, ladies, how about a question? If marking that pre-op, Jennifer, why don't I open up the mic? Let me unmute everyone. Hang on, let me get to my attendees.
I got Jennifer open for you.
Jennifer, did you have a question? I've got you unmuted. I think you may have to unmute yourself.
Can you hear me? Hello?
I can hear you, Jennifer.
Oh, you can.
Jennifer, can you hear me?
Now I can, yes. So it looks like in that picture on the other side, I don't see
Do you
any.
have a question? Just put it in the chat box, yes or no.
Oh.
You've got a question.
We must be having issues. Sorry,
Yes.
Jennifer.
Jennifer, can you speak your question?
Can you hear me now?
I just sent Joy a message that I can hear you, but she cannot.
No,
so
I can't hear her.
Okay.
So go ahead, Jennifer, if you can. Oh, everybody can hear Jennifer.
Why can't I hear? Did I shut something
Go
off?
ahead and ask the question.
Yeah, go ahead, Jennifer,
Again,
and I'll
Jen.
try to relay.
Oh, I hear something now. I hear something
go
now.
ahead.
So I noticed that in that picture, on the other side of the abdomen, there didn't seem to look like there was going to be a crease, and it seemed to look like it was in the the highest point of the infraumbilical fold. So do you think that if we had marked it on that same spot and then it just created a crease after the surgery, does that happen?
I've seen that happen. I have seen that happen before, very vividly on one that my friend had marked one time, and I was with her when she went in and she marked it, and it was the perfect location. But later on, I saw it after the stoma had been created, and creating the stoma created that contour in it. I mean, it wasn't on the person's body prior. And the person kept saying it was marked in the wrong place. It was marked in the wrong place. No, it was marked in the right place, but creating the stoma created that contour in there. So yes, I have seen that happen. And it's devastating when it happens. It's usually on those gushy, soft, obese type abdomens. But yeah, unfortunately, I've seen that happen before. Had you ever seen it happen?
Yes, I have.
Yeah, they're limited. It's not like the intestine is a piece of water hose that they can just pull up as much as they want. They've got to keep it connected to that blood supply. And so sometimes there can be tension on it where the stoma's pulling back down. And I think that's one thing that helps that crease develop. Yeah, it's like Anita said, because they can't pull up enough.
Okay, thank you.
You're welcome. You're welcome. You have any other questions? Carissa, any questions from you?
I can unmute you, Carissa.
Oh, do go ahead and unmute her. Let's see if she's got something to say.
Go ahead. You have to unmute yourself. There you go.
I'm good. I don't have any questions.
All right. Well, why don't we go to lunch? And we will come back at, if I got 5 till, I do. So we will come back at 5 till 1. Sound good? Yes, Joy. Okay, y'all. Bon appetit. See you at 1 o'clock. Thank you.
Oh, okay. Phew. That was rough. Oh my God. Hey.
Anita, call me. actually spend a couple of days going and showing the different types of ostomy products. But what we want to capture this afternoon are the big categories of the products that include not just the pouches, but also some of the accessory products as well. Now, when we're talking about the pouch, we're talking about their appliance. An appliance is one of the terms that we use to refer to their pouching system. And when we're talking about their appliance, we're talking about, you know, the skin barrier, the pouch, or just the pouching system, but whatever their system is. And we use this appliance for our incontinent ostomies to collect their effluent, their output, whether it be urine, stool, mucus, or gas. When we're talking about the appliances, the categories that we can put them in, to start out with, it's going to be 1-piece and 2-piece. If it's a 2-piece system, you've got 2 separate pieces. And of course, if it's a 1-piece system, well, you figured it, it is all put together. Let me grab one of these that's all put together. So you've got your 1-piece, you've got your 2-piece, you've got fecal, and you've got urinary. And then you can also see that you're going to have another category that's going to be high output. And then you can get on down to even more specifics, like filters, opaque covers, you know, different things like that. Appliance, as I said, that's just the general term when we're talking about their pouch, but we're talking about their whole system. If they wear a 2-piece system, when we say appliance, we're referring to everything it takes going into putting this on that person. So we're talking about the skin barrier and we're talking about the pouch as well. People use different terminology. Some people call these pouches. Some people call them bags. Take the term, whichever one you feel the most comfortable with. I think you'll probably hear me say pouch more often. And the reason is that's just the most common terminology that I use with it. I will say that bag just sounds harsh to me. And I think the reason is every time I have heard of an ostomy mentioned in some kind of negative way, they were calling it a bag. I don't think I've ever heard it used negatively when they refer to it as a pouch. But that again is just my preference. You go with whatever you feel comfortable with. Now this, we call these different names. We call them wafers. We call them face plates. We call them base plates. We're trying to get on the same terminology now and just call them barriers. Just the barrier. You can call it skin barrier if you want. But the reason we're trying to get familiar terminology here is because in the DME catalogs, you don't usually see the term wafer or faceplate. Most of the time they call this the skin barrier. Well, this is the part that is going to have the adhesive on it. And it's the part that attaches right to the pouching system. And when I'm talking about skin barrier, this is what I'm talking about. I'm not talking about your moisture barrier or your liquid film barrier. As we're going through this, we're going to take a look at several different videos. These videos are from the American College of Surgeons. And I noticed it was starting to play and I didn't hear any sound. So I am keeping my fingers crossed. We're not having audio issues. And I want you to know, Carissa and Jennifer, last week I taught this course, and do you know how many technical issues I had? None. You know how many technical issues Anita had? None. So I guess we're catching them this week. Let's see. Hopefully I won't have an issue. I'd like to show the following video, and this is about ostomy appliances. And I have no idea why the sound is not working. All right, I'm going to escape. And I am going to come back in. And again, y'all,
Pouching systems. You won't be able to feel or control the stool or urine as it leaves your body through the stoma. So you will need to wear an ostomy pouch system or ostomy appliance at all times. The pouching system sticks or adheres to the skin around the stoma. The pouch collects stool or urine, contains the odor, and protects the skin around the stoma. Urine or stool on the stoma will not cause any problems, but urine or stool on the surrounding skin can cause the surrounding skin to get red and break down. Ostomy pouching systems are lightweight and lie flat against the body and can be worn inside your underwear. Pouching systems come in different sizes and styles. Your doctor or nurse certified in ostomy care can help you choose which one is best for you. Most people try several types of pouches before they choose one permanently. Now, let's talk about the different types of systems. One-piece systems. A system can have one or two pieces. In a one-piece system, the pouch and skin barrier are attached together. Two-piece systems. In a two-piece system, there is a skin barrier, also called a wafer, and a separate attachable pouch. The skin barrier adheres to and protects the skin around the stoma and gives you a place to attach the pouch. The skin barrier usually includes a flange or rim to seal the pouch to the skin barrier. Flange sizes are made to fit exactly to a specific pouch. Drainable pouch. A pouch can be drainable or closed-ended. Drainable or open pouches have an opening at the bottom to drain the output. They are closed with a clip or a roll-up seal for a colostomy and ileostomy, and a tap for a urostomy. You don't need to remove a drainable pouch to empty it, so it can remain in place for several days. Drainable pouches are easy to empty and an option for people with ostomies that need to be emptied several times a day. Closed-end pouch. Closed-end pouches have no opening and cannot be emptied. When they're full, you throw them away. Since you could use 5 to 7 pouches a day, you'll need to carry extras. You'll also need plastic bags where you'll place the full pouch before putting it in the trash. A closed-end pouch is often used when the pouch does not have to be emptied often, for convenience while traveling and during intimate moments, because it is less bulky and has no clips or seals. Pouch closures. There are a number of different closure methods for open-ended pouches. For ileostomy and colostomy pouches, a roll-up and seal method or a clamp is used. When using a clamp, be sure that you only wrap the end or tail piece around the clamp one time. After you close the clamp, tug on it while holding the bag to make sure the clamp is in place and doesn't slip off. Clamps usually last a month or longer. All urostomy pouches are drainable and have a valve that prevents the urine from backing up around the stoma. The drain can be a tap that turns to open or close, or a drainage nozzle that has a plug or bends up into its holder. A tap on a pouch will have a small marking that tells you whether it is open or closed. All drainable urostomy pouches can be attached with a larger drainage bag to keep the pouch empty while you are sleeping. See your booklet for full instructions on daily care and nighttime drainage of your urostomy.
Now, did you notice right there at the end that she was putting that adapter on? We'll talk about that adapter a little bit later. So that video, I think is a really good, thorough video. And I can't tell you how many times I've gone to YouTube and I've looked it up, and it's very easy to find. You go to YouTube and search the American College of Surgeons, and then it's going to pull up all of their videos. And if you put in ostomy skills, it'll be the one that's in the ostomy skills DVD. Now, mind you, that DVD that has these videos on it is in the book that is in the skills kit that you have. But I think it's just a really good video to give an overview of the different pouches as well as the different types of closures on the bottom of them. All right, so when we're talking about our appliances, what are the goals that we have with the appliance? Number one, it's to provide the person a reliable, predictable wear time. And that wear time needs to be at least 3 days. And we typically aren't going to go over 7 days. Most of us, we like to see the skin, what's up, what's up underneath any adhesive every 7 days. The appliance needs to be inconspicuous. We need to be able to hide it away up underneath our clothing. It needs to be comfortable. It needs to move with us. It needs to be easy for us or the caregiver to apply it or remove it. And when I'm saying us, I'm talking, I should have said the patient, but us too, as clinicians, to apply it and remove it and empty it as well. And it needs to function well with odor. It needs to contain the odor. And if it's working properly, the only time there'll be any odor is when you're emptying or removing the pouching system. Other goals are it should protect that peristomal skin, and it should be cost effective. Now, when we look at the picture, I think, hey, this skin has been protected. Look down there on the bottom right, and you can see, hey, that skin has healed. Top left, day 1, that's what it looked like. Now day 3, it looks like this. I can say, hey, they protected that skin. They have allowed it to heal. What have they protected it from? Well, it looks like there's probably been caustic effluent on there. That's an ileostomy. So my guess is caustic effluent has undermined their system. It's really, really irritated their skin. And so now they're putting a wound manager on there. That is a really large Eakins pouch. Depending on the contract, that could be anywhere from, I don't know, $50 to $100, depending on the contract. And you got 3 days wear out of it. So now I'm getting to the cost-effective part of it. I totally agree that a hydrocolloid cover, which is what you're getting with that wound manager right there, is appropriate to help heal that skin. But I don't have a lot of wound managers like that I can use with an ostomy. If I've got a wound manager like that, I'm saving it for my wounds. So what I could do is create that same environment that you created with this hydrocolloid device by using a hydrocolloid skin barrier rather than using a skin barrier that has tape on it. I'm going to make sure that I use an all hydrocolloid skin barrier, and then I could use any hydrocolloid that I had in stock around it. That could be a Tegasorb, it could be a Duoderm. And then you know what? I actually could leave it on a little bit longer if I needed to. I could change the skin barrier, but I could leave the other hydrocolloids in place longer if I needed to. So we got to balance the factors. Yes, there are so many different pouches out there on the market. We can find a pouch for just about anything. But is it going to be cost effective? It's our responsibility to help the patient or their caregiver find the appliance that's going to work right for them prior to their discharge, but also throughout their lifetime with an ostomy, because it's going to take that good fit for this person to get back into the game of life and find their new normal. So let's look at some considerations when we're talking about our appliance selection. Number one, when you're choosing the appliance for the person, what does their abdomen look like? And I'm going to tell you right now, I will not be choosing the same pouching appliance for both of these people. The guy over there on the right, well, I could choose a flat one-piece pouching system. He's got a colostomy, so it could be a flat, closed-in one-piece system. That'd be something. But another option for him might be colostomy irrigation. We'll come back to that. And I'm kind of leaning toward that because that guy has got a tan underneath where that pouch right there is, where the pouch sits. You can tell Joy's been looking at that picture way too long. But yeah, it looks like he's been wearing a stoma cap right over that area because he's tanned up underneath it. But in any event, I could go with a flat, just pretty much any skin barrier on that guy. Why? Because his pouching plane is free from wrinkles. no creases, no contours, as opposed to the photo on the left when this is an older person with older skin. It has that more crepe-like appearance. And it looks like there's a lot of loose skin. Maybe this person has lost a considerable amount of weight over that time. Yeah, it's going to be harder to find something that's going to stick appropriately to this person's skin as opposed to the person on the right. The one on the left, yeah, I'm going to need convexity. I'm going to tell you right now, convexity and a belt to help hold this in place. I've got to think about other things too when it comes to the application of this product, such as the age and the manual dexterity and the visual acuity of the person who is going to be managing this. Is this somebody with poor vision, or do they have a caregiver that's taking care of it? Is this somebody who has rheumatoid arthritis and they're independent? Well, I'm going to have to work around those factors. And these two ladies, both of them in this, that's depicted in these pictures, both of them have the use of one hand. And you see how they're using their teeth, their mouths, to help get into these packages and take the backings off of them or to even pull them out of the package. That's what it takes to keep them independent. So what would you do if somebody came into your office and they had the use of one arm, and now you've got to recommend products? What brand are you going to recommend? Do you know which brands are easy to open with your teeth? Yeah, I never thought I would need to know that. But last year I had a lady who came to see me, and she told me before she left her house, and so I had like an hour to prepare for this. She told me that she only had the use of one arm. And I said, okay, well, we will figure it out when you get here. And I thought of this picture. And I went into my office and I started opening packages with my teeth to see which ones were going to be the easiest for me to open, thinking that's what I would recommend to her. Again, something I never thought that I would have to do. But that's just how individualized your patients are going to be. Everybody's going to have their unique needs that they're going to have. All right, what about the person's mobility? Is this somebody who wants to go diving or go swimming? Hey, I'm going to show you some swimsuits tomorrow. That would be wonderful for the person who wants to go swimming. And if my patient wants to play soccer, I'll be showing you several different guards that they can use. Guards that protect the stoma, and then guards that protect the pouch as well. And the lady in the red dress, that is a very form-fitting dress. If she's got a urostomy, I want to recommend a system that is going to be the most low profile for her. So I want to make sure that it's a urostomy pouch that has the different chambers in it, not just a big, a big full reservoir of urine. And then, if she wants to go swing dancing, I'm going to find her an even shorter urostomy pouch. I've also got to consider the size of the available pouching surface. Do they have retention sutures? That's going to limit the available surface that I have to pouch on. Or do they have creases or folds in their skin, like the picture on the right? How about these contours? Creases and fold that change when the person changes their position. Yes, I'm going to put the pouch on the person in one position, but I can't expect them to just stay in that position. So I'm going to have to make sure that the pouch not only fits them in the position that they're in when I put that on them, when I put it on them, I'm going to have to also have them get in other positions as well, so I can see those contours advance and change on their body and make sure it's not knocking the pouch off in the process. When you're doing your stoma assessments on your patients, make sure that you capture all the detail that you can. I really encourage you to use a stoma assessment form, such as the one that Anita pointed out. It's in the back of your book. As she said, Donna didn't trademark it. You can take it, mix it up, use it any way you want. As a matter of fact, on the back of the stoma assessment form, I covered up one section and I left it blank because I always ask my patients, what are your hobbies? What do you like to do for recreation? And one of the reasons I ask them that is trying to figure out their dexterity. You know, is this a woman who's going to say, oh, I love scrapbooking, that's what I like to do? Well, if she tells me she likes scrapbooking, I know she's going to be able to cut those skin barriers out like nobody's business. If it's a man who says he likes to go fishing, I'm going to think, well, he's probably got pretty good dexterity to be able to bait the hook. But you know, even if they tell me, oh, I don't have any sports interest or hobbies, I just sit around and watch Netflix. Well, I want to find them a pouch that's going to be comfortable while they're sitting around watching Netflix. So on the back of my stoma assessment form, like I said, I have a blank area that I fill in with sports interests or hobbies, whatever they like to do. You can do that yourself, just modify it however you want to. But you want to capture all the information possible. So when you're coming back to look for these products, you've got the information that you need. When you're thinking of the product that's going to work best for that patient, consider what you normally have in stock. If this is an inpatient, this is long-term care, and you're providing the product, and it's something that you've got to stock, when you're choosing what's right for them, think about what you've got in stock. Think about cost, extra cost to the patient. And does the patient have insurance, or is this an unfunded patient? If they are, they've still got to have supplies too. So we're going to have to make sure that we know where some accessible supplies are. Things that we've got to consider with our pouch selection, post-operatively, we're going to go with that clear pouch. We need to see the stoma. We need to see the output. And the patient needs to, this is a learning process for them. So they need to get to know their stoma and their output. And a transparent pouch is what's necessary to be able to do that. However, there's no reason why you can't go ahead and show the patient pouches that are what we call opaque, that you can't see through. Wear time, that's the patient's preference. They can change it however often they want to. We do recommend it's changed before it starts to leak, and we recommend that it's changed at least every 7 days. The size of the appliance that they want to wear, well, they can wear a small appliance. They'll have to empty it more often, but they can certainly wear a small appliance. Now, when I'm talking about the sizes of appliances, let's take a look at some different appliances. This is a 2-piece system. This one is by Coloplast. Now, I'm going to throw up several brand names throughout this presentation. When it comes time for your exam, you won't be tested on any brand names. But I'm saying these brand names because you might want to write it down and get used to them. There's not a whole lot of manufacturers here in the United States, but you do want to be familiar with the ones that are here. This one is Coloplast, and this is the Mio system. It's unique in the fact that it's gray. There we go. And this is a Hollister system right here. There we go. Again, both of these are 2-piece systems. This is a 1-piece system, kind of higher output. This is a 1-piece closed end, very flexible. And this is a 1-piece urostomy. I mentioned chambers in it. This one has the chambers in the bottom that will allow the urine to flow, but the pouch doesn't, expand like just a big bag full of urine because of those chambers that are in there. And let's see, I want to get to my smaller size pouch. That's what I'm looking for. Here we go. And both of these pouches right here are smaller. So when it says patient preferences, do you see the differences in these 2 pouches? How about this closed-ended pouch as opposed to this closed-ended pouch? See, smaller. And they actually do make a closed-ended pouch larger than this. And here's one that's a little bit larger. This is a different brand right here, but this just gives you an idea of different sizes. And there's no reason why we can't go ahead and show the patient these, although we're telling them, you're using the clear right now so you can get to know the stoma. After you've gotten used to your stoma, the output, you start ordering these. You can order opaque, so you don't have to see the contents. The brand, the exact product that the patient's going to use is up to them. It really is. And there's not a right or a wrong choice. Well, I would say maybe there's a wrong choice if it leaks, but the person needs to experiment with the different brands. It may be that one of the big three, Hollister, Convatec, Coloplast, one of those might stick better than the other one does. It may be that the person's in a dry environment, or maybe they're in a humid environment, and one of them just tends to stick better on the person. We like for patients to trial everything that they can. And it's not just from the big three manufacturers. There's also New Hope and Marlin and Symed and Salts here in the United States. Let's start out talking about the skin barrier. This is what I'm talking about. I'm talking about the skin barrier. It has two main functions. Number one, protect the skin. Number two, it's the junction that connects to the pouch. And if the skin barrier is working correctly, the skin is going to be in good shape because the skin barrier is keeping the effluent off of the skin. Now, what these are made of, it varies a little bit from manufacturer to manufacturer, but the main ingredients are your hydrocolloids, your tackifiers, and your polymers. Let's look at each one of those. Your hydrocolloids, when you think hydrocolloid, think of products like Duoderm or Tegasorb. Those are products that have been around for a long time that kind of represent the hydrocolloid category. And you would use a product like that if you had a stage 2 pressure injury. So the epidermis is gone, a little bit of the dermis is gone, and it's weeping a little bit of moisture, so you have to put something on there. Many times we use a hydrocolloid. The hydrocolloid is sticky, and it's going to absorb a little bit of moisture. You know, it's not like that stage 2 pressure injury is a highly exuding wound. It's not. But the skin, when it loses the stratum corneum, oozes a little bit of moisture. Well, the hydrocolloid is going to be able to absorb it. Within the hydrocolloid, it's made of carboxymethylcellulose and pectin. You know, we get pectin from different foods that we eat. And gelatin. Gelatin is also in the hydrocolloid. It's what gives it its strength. All right, so the hydrocolloid, that's one component. The next component is the tackifier. Tackifier, think tacky, think sticky. So the tackifier is what provides the adhesive, the stickiness. And this stick is going to be dependent on a little bit of pressure. When we're talking about the tackifier, you have got to make sure that all of this skin barrier comes into contact with the skin for this to stick adequately. And this stick is dependent on the little bit of pressure that we're applying. These skin barriers are pressure sensitive adhesives. They have to come in complete contact with the skin for them to stick appropriately. Not only are they pressure sensitive adhesives, they've got dry tack. You know what dry tack is? Think about chewing gum. When you chew gum, the gum doesn't stick to your teeth. That's because your teeth are wet. But if you spit that gum out and step on it with your shoe, it's going to stick to your shoe because your shoe is dry. Yeah, gum has dry tack. These do too. These are going to stick to dry skin, but guess what? They're not going to stick to wet skin. Just like the gum doesn't stick to your teeth, these are not going to stick to wet skin. Okay. So these are pressure sensitive devices and they have dry tack. Again, make sure you have good, solid pressure. Polymers, that's that third component I was talking about. And with the polymers, when they're warm to body temperature, they're going to flow onto the skin. Now, when I say flow on the skin, I don't mean flow like, you know, urine would flow onto the skin. What I'm talking about are the polymers. This product itself having the ability to fill in the little creases and crevices of your skin. And when I hold my hand up and I have the reflection of the light, I've got a window in front of me, and when I have the light shining on it, I can see all these little creases and crevices in my skin. Look at the back of your hand and see if you've got creases and crevices in your skin. I do. And you know what? The skin on the back of my hand is the same as the skin on my abdomen. And if I did have a leak up underneath my skin barrier on my skin, these little creases and crevices in my skin, although they do look small, well, that liquid would find it, and that would be just like a ramp for that urine or liquid effluent to run through. So the polymers in the back of the skin barrier are going to flow into these little creases and crevices on my skin and then prevent any liquid or moisture from being able to gain access to it and leak. So that's what the polymers are. The polymers are able to stretch and go over this area. Now, as you're looking at the picture, right there on the top right, you see the skin barrier just laid on top of the skin. You can see the gaps in between the skin surface and the skin barrier. But when it's warmed, you apply it, and you can see that the polymers went and filled in those little gaps. That's what you want. For those bottom two pictures, you would rather have the good adhesion on the bottom right as opposed to the poor adhesion on the left, where you're left with those little gaps that the liquid could find and cause a leak. Okay, so we talked about the hydrocolloids, the tackifiers, and the polymers. Now, Coraya, they make Coraya pouches as well. We don't use Coraya as much as we used to, but it was really popular back in the 50s and the 70s. Coraya is an all vegetable product that comes from the bark of a tree from India. And it has a low pH, a pH of about 4.5. That makes it bacteria static, and it can neutralize E. coli. We use Coraya whenever somebody has sensitivities to adhesives. What you're looking at is a Coraya type ring over on the right hand side. This would be very similar to like your E-Conceals or Adapt rings or moldable barrier rings, moldable seals, whatever brand name you go by, except it's made out of the Coraya product. And it can be used, you can flatten that out and make it a barrier in between the product and the person's skin, or it can be used as the adhesive to help hold different products on. Let's go over some terminology. First bit of terminology is going to be wear time. What's wear time? The wear time is the length of time the product can be worn before it fails. And failure means it has started to erode away. And when it erodes away, it becomes wet, as you're seeing in the picture on the bottom left. It becomes wet and starts to pull away from the skin surface. As you look at the back of that skin barrier, you can see the wear pattern. You can see how urine was absorbed by that hydrocolloid. And as that hydrocolloid absorbed that urine, as it absorbed the moisture, you can see that it started to swell and break apart. That's what hydrocolloids do. That's no different than the Duoderm or a Tegasorb if it was absorbing the moisture from that stage 2 pressure injury I was talking about a few minutes ago. It would be no different. That's what hydrocolloids do, and that's what they do up underneath the skin barrier. You do want to make sure that you look at the back of the skin barrier every time you take the pouch off, because you're looking for wear patterns. Where did you have any leakage up underneath it? That the leakage was just held there because the hydrocolloid was absorbing it. Now, erosion, that's another term. Erosion is going to be influenced by the amount and the moisture and the amount and the moisture content of that person's effluent. It can be effluent, but it could also be sweaty eddy right there with perspiration, and different people perspire different amounts. And another thing that influences the amount of erosion is the type of skin barrier that you're using. In a few minutes, we're going to talk about regular or standard wear and then extended wear skin barriers. When you have erosion, that's going to cause exposure of that peristomal skin to the person's effluent. And if the skin is already jeopardized, it can break down really, really fast. Once it breaks down, nothing's going to want to stick to it. Remember, your skin barriers have dry tack, so they're not going to want to stick to that wet, raw skin. Wear time, I would say the average wear time for most people is 4 to 5 days. Many people change twice a week, and several people just have routines like every Tuesday and every Friday. They just routinely change on those days. The person wants a wear time that is allowing them to achieve that reliable, predictable wear time pattern. Now, there's something called silent erosion. Silent erosion happens when the skin barrier is starting to erode away on the inside. When I say the inside, I'm talking about right here. But the person doesn't know it, and they aren't leaking out on the sides. There's no leakage. The back of the skin barrier, the hydrocolloid, it's absorbing that effluent. It's swelling and it's starting to break apart, but it's absorbing it. Now, as it's absorbing it, it's holding it right there on the skin. So if this is ileostomy effluent, think about that effluent. You know, think about what's happening in the small intestine. Food's being broken down. It's being digested. So that's some real caustic effluent right there. And if it's being held right up against my skin, well, it could break that steak down inside my GI tract. It's going to break down my skin like it's butter. So I've got to get it off the skin as soon as possible. To prevent silent erosion, you got to catch it. So what we want is we want the person to learn when they're removing their skin barrier, remove it and look at the back of the skin barrier. Look for any wear patterns, just like you're seeing right there in that image. Peel it away and look at the back of it. See if there's erosion. And if you do see an area of erosion, look on your skin and see if you've got irritated skin in that area. Quick question. A function of the hydrocolloid in the skin barrier is very good. Very good, ladies. Used for the enhancement of that moisture. One of the reasons patients should use a transparent appliance postoperatively includes which of the following? That's it. So the effluent and the stoma can be visualized. A goal of the appliance is to provide a predictable, reliable wear time. What's considered typical wear time? Did you both answer that? All right, and it is 3 to 7 days. Yeah, so you know that gives a person some leeway. That gives them some leeway. Now, earlier, to be honest, it said 4. It said 4 to 7 days, I think. Okay, I told you before we were going to talk about regular wear and extended wear. So you've got options here. There's regular, also known as standard wear skin barriers. Now, your regular standard wear skin barriers have a high flow, so they can really flow in. Those polymers can flow into the creases and crevices of the skin, giving really good stick, good adhesion there. You do want to make sure that you warm this up, and then after it's applied to the skin, that you still keep applying some warmth. That's typically done with just the person putting their hands over that area. Your regular wear or standard wear products are able to absorb moisture more quickly. Now, all in all, they absorb less, but you just remember they absorb the moisture more quickly. They are going to disintegrate faster than your extended wear, but that's because as the hydrocolloid absorbs the moisture, it swells and it breaks apart. But hey, it's absorbing the moisture, because look at it this way. If that hydrocolloid didn't absorb the moisture, think what would happen if the person was just sweating and sweating and sweating and the hydrocolloid wasn't absorbing the moisture. Well, that would be like leaving this paper. Now this is this clear, this paper guard right here. That would be like leaving this on and putting it up against the skin. All right, so let's just have the skin start sweating and sweating and sweating and sweating. What's going to happen with this? Well, the hydrocolloid's not exposed. I've got this paper sticking on there and it's not going to absorb anything. So with all that sweat, this is just going to fall right off. Well, guess what? Extended wear products don't want to absorb. So if you've got sweat and your product doesn't want to absorb that moisture, absorb that sweat's just going to build up in between it. So if the person is sweaty, we need them in a regular or a standard wear product. That way, when they sweat, the product can absorb some of that perspiration. Yes, it's going to start to swell up and break apart, but I can still give this person that 3 or 4 day wear time that is going to be a reliable, predictable wear time. That's good. This would also be very beneficial for somebody who was in a humid environment as well. Now, your standard wear products, they work really good for colostomies because the output is thicker. Stomas don't function as often. And the feces output is not going to break down the skin barrier the same way that the caustic effluent from an ileostomy could break it down. Your regular and standard wear products, these are used for more frequent pouch changes, like the one-piece closed-in pouch I'm wearing right now. This is one of them. Your extended wear, on the other hand, they have special adhesives in them. It's a stronger adhesive, but just because I say it's a stronger adhesive, that didn't mean that that regular wear wouldn't ever make a 7-day wear time. Yes, it would. If Sweaty Eddie had some days where he wasn't sweating so much, he could probably still get a 7-day wear time out of the regular wear. I don't want you to think that extended wear just gives them a longer duration of wear time. To me, what this comes down to is how it deals with the moisture. Okay, your extended wear, as I said, this has special adhesives. It's stronger, it's a stronger adhesive, but your extended wear product is going to be more erosion resistant. More erosion resistant. If there's moisture on the skin, this one is going to absorb it at a way slower rate. So if it's not absorbing it very fast, it's not going to be swelling and breaking apart either, is it? So I would use this for my wet ones, like my ileostomies, my urostomies, and my colostomies that have really liquid stool. Makes sense that I would want to use a product that's not going to be absorbing the moisture from that urine, right? That's what I need, something to stand up against it. Well, that's going to be my extended wear. Now, with my extended wear, the companies create these to go right on the skin. And they really don't want us to take some type of barrier film and rub that on the skin and put it in between the person's skin and the product. They would prefer that we not do that. They would just prefer that we put their product right on the skin. How do you tell the difference? How do you know? Is it regular wear? Is it standard wear? How do you know? Well, it's on the box. For some products, you may know that, okay, the little ring right here, if it's this color, this one means that it's, I was looking to see if this one was a different color, but it's not. I think one of these colors is going to be your standard wear, and it's more of a gold color if it's extended wear, and that color, it might be vice versa, but that's what I'm talking about. With Convatec, Convatec has Stomadhesive and Dura-Adhesive. Stomadhesive is your regular wear. Dura-Adhesive, Dura meaning more durable. That's your extended wear. Now, when Coloplast came out with the Mio, they made it a combination of the two. So it's not a regular or an extended wear. It's just a combination of the two. The flange. Let's talk about the flange. Let's get this pulled apart so we can see some flanges. Come on off of there. Here we go. That's the, as they say, the Tupperware part. Find another one right here. Hollister's got a very good example I'd like to show you. This is Hollister's flange. That's one part of it, and then it's got a skin barrier that matches it. I need a bigger desk, but I'm sure if I had a bigger desk, I would have more stuff on top of it. All right, this is the flange. This is the connection part. And depending on the brand you're using, it can look a little bit different. So the flange, as I said, come on. We'll take a look at the Coloplast locking flange. This one is a delay before they start talking, but he should have started talking by now. Y'all, I apologize for these audio issues. Come on. He should be talking. All right, we will come back to this one. We will come back to this one, and I will show you what they just showed you. This is the two-piece system. It's different than your Tupperware type flange because this one has the locking ring on it. Now they showed you the older series. This is the Mio line, so this is the new series. The two pieces snap together. I got it snapped together. There was the locking ring. Now this locking ring, you can spin this ring around and it can be on either side, right side or left side, depending on your preference. But get it where you want it. And by the way, I'm going to put it back over here on this side and lock it into place. And when you lock it, you can hear the click. And that is not coming off of there. Yeah, in a classroom, if I was in the classroom, I would hold this and I would have somebody pull on it. I've never had anybody who's pulled it loose. I've had people that have pulled me almost across their desk, but I've never had anybody that's pulled it loose. When you want to take it off, you simply mash that button. There we go, and it unlocks. There we go. And then I'm going to peel it off. There we go. Okay. Now lifting flanges. There's lifting flanges, and the best one to demonstrate with at first is going to be Hollister's, because Hollister is the first one that brought this one to market, and it was their floating flange. They call it a floating flange because you're able to get your fingers right there up underneath the rim. What's the deal about getting your fingers under the rim? Well, if you couldn't do that, this would be stuck to the body and you would have to secure the pouch just by pressing it down. But now that you can get your fingers up underneath the rim, you can snap the two pieces together and not have to be pushing straight down. So post-operatively, patients love that. Now, they're the only one that has this little lip that lifts up. Convatec last year came out with the accordion flange, and they have an area that lifts up further than this, that you can get your whole fingers, the ends of your fingers in, not just right here at, your fingertips. You get a lot more of your fingers under the accordion flange, and then you can press it back down flat. I do believe I have one of those. I'm sure I'll come across it sometime this week and make sure that I show it to you. Now, the opening that's in the skin barrier. So I'm talking about this opening right here. Here's me an opening. Where's me another one? This one is pre-cut right here. This came from the company just like that. And then I have another one right here that is moldable. Right? And that's our 3 different forms that they're going to come in. Cut to fit. It has a starter hole and then the lines around it. Pre-cut, so the opening already comes cut to a designated size, and moldable. Cut to fit. Well, who's this going to be good for? This is going to be good for that stoma that's irregular or not round. And it's going to be good for that stoma that's still changing in size postoperatively as it shrinks down over that first several weeks. Your pre-cuts come in a wide variety of different pre-cut size openings. And most of these are only going to be cut in a round opening. So if you have an oval stoma, you do want to be making sure that you're protecting any unnecessarily exposed skin. And then finally, moldable. This is an example of moldable right here. And moldable, just like it sounds, you are going to mold this. Now, what you're going to do is you would actually use your thumbs and just roll it back the same way I use my forefingers and rolled it back just like that. And what is going to happen is the stoma is slowly going to close up around this. It's going to come up and kind of turtleneck right around it. Now, a moldable skin barrier is allowed to touch the stoma, but your cut to fit and your pre-cut, no. There needs to be about 1/8 of an inch in between the skin barrier and the stoma when it is a cut to fit or a pre-cut. But moldable, this is going to be really soft and pliable. And like I said, it can roll right back up against the stoma. It's designed to do that actually. And then do what we call turtlenecking, as it just swells and it kind of creates a turtleneck to help prevent leakage. Let's watch a short video from them about it, and let's hope we've got some sound. Everybody, let's take 5 minutes for a break. Is that okay? I've got to figure out what's wrong with my sound here. So I'm going to set the timer and we are going to take a 5-minute break. Do y'all mind that, ladies? Carissa, Jennifer, I want you to have some sound so you can hear what I'm talking about. Thank you.
What's the issue that you're having, Joy?
Diane, I have no idea.
No, I mean, what is the problem? What are you experiencing?
I've got no sound with my videos. Have you heard them say anything?
I'll be honest, I had the volume down.
Well, the sound doesn't come off on the video. The video will start, but the sound does not follow it.
And I've not had that. So I'm going to give it a shot again. This is aggravating.
Otherwise, I have the videos. I can put them on a YouTube account for them to see.
If I have to, I'll show them tomorrow. I just realized I did an update yesterday. Yesterday when I was working on it, it came up that I needed some update and I did it. And
yeah, Yep, that's gonna screw it up.
Yes, I'll figure it out tonight, and any videos I can't show, I'll show them tomorrow. But I just thought about that update. Man.
Before attaching the bag to the base plate, you must ensure that the lock is open by pressing the small.
Okay, thank you.
Those are working.
Yeah, it's working now.
Yeah.
Oh.
Maybe
I
you
hate
shouldn't
that.
have said anything.
Oh, thank goodness it's working. Thank goodness it's working. Okay, whew, got 5 minutes to got that ironed out. I sure am glad. I sure am glad. Jennifer and Carissa, are you still with me? Did you pop up and run, get you some tea or something to drink? If you're still with me, I'll start back. But if you're not, that's fine. We'll finish this 2 minute and 12 seconds.
When they do get back, Joy, Jennifer had a question in the chat box. So
Carissa's back. Jennifer. Oh, I'm glad she asked. I'm glad she asked. Jennifer, are you there? Lynn, thanks for pointing out that question.
you bet. It came just right before the video and before you did the 5 minute. Everybody's back.
All right. Jennifer, you're back?
Yep.
Okay. How can you tell, Lynn?
She mentioned it in the chat box.
Oh, okay.
I
Okay.
can stop the timer for you.
Thank you. Thank you.
There you go.
Okay. Jennifer had asked the question, moldable. Is it available in regular wear and extended wear? Yes, it is. Yes, it is. Moldable is available in regular wear and extended wear, and moldable is available in your flat skin barriers and your convex skin barriers as well. It really is. Okay, well, the sound started working, so let's take a look at moldable. Okay, so what about the sizing of the skin barriers? Well, the sizes of the back of the skin barriers, they're identified by the largest opening that can be cut in the skin barrier. And this can be variable. So this one right here is a 1 11/16, or we can call it 43 millimeters. This one is 76 millimeters. And this one, fresh to the market just last year, this one actually goes up to 4 inches right here. So you have variable different sizes. Your standard increments are going to be your 10 to 75 millimeters. So like I said, they're identified in the largest size that can be cut, or if it's pre-sized. Now, if this was a pre-cut opening, it would be identified by the opening that had been pre-cut in it. As I said, the opening needs to be about 1/8 of an inch in between the skin barrier and the stoma itself, with the exception of moldable. I put a little stoma in the middle of it, and you can see how it's rolling back up around the edges, kind of turtlenecking right there. Moldable can touch the stoma, but you're cut to fit and you're pre-cut. The skin barrier needs to be about 1/8 of an inch away from the stoma. That's going to be enough to allow the stoma to move with peristalsis, or let's say there can be a little bit of trauma or movement from a seat belt right up against it, and it pushed the stoma a little bit up against the skin barrier. Well, with 1/8 of an inch, that gives a little bit of wiggle room in there.
Let's have a look at how to prepare the ostomy adhesive before application to the skin. The hole in the adhesive must fit precisely to the shape of the stoma. If the hole is too big, the skin around the stoma is exposed to the effluent from the stoma and may be damaged. If the hole is too narrow, the adhesive cannot adhere to the surface of the stoma. A hole that is too narrow might also damage the stoma. For custom cutting the hole in the adhesive, you will need a stoma guide, a pen, and a pair of curved scissors. The diameter of the stoma will change over time, so make sure you always keep a close eye on the size of your stoma. To measure the diameter of your stoma, use the stoma guide. Try the different pre-cut holes in the stoma guide to find the hole size that best fits your stoma. If the hole is too big, the skin will not be protected properly. If the hole is too narrow, the adhesive will not adhere properly. The hole must fit precisely to the size of your stoma. If your stoma is oval, measure the different diameters of the stoma using the half circles of the stoma guide. Having measured the size of your stoma with the stoma guide, use the stoma guide to draw a cutting line matching these measurements on the back side of the adhesive. Pull away the bag a bit to ensure you don't damage the bag itself while cutting the hole. If your stoma is regular and you know the diameter of the stoma, just use the pre-printed cutting guide on the back side of the adhesive. If you don't know the diameter, use the stoma guide. Pull away the bag a bit to ensure you don't damage the bag itself while cutting the hole. To cut, use a pair of scissors, not too big, and preferably with a curved shape. When you remove the protective film, you can save it as a guide for the next time you prepare an adhesive.
Okay, quick question. Regular or standard barriers are good to use for individuals who perspire heavily and humid environments. True. Very good. Very good. Another question. Extended wear barriers are more resistant to erosion from effluent. Extended wear barriers. That's it. True. Very good. Very good. One more. Skin barrier openings are available in 2 forms, cut to fit and pre-cut. False. That's it. 3 forms, because there's also moldable. Very good, ladies. Very good. All right, now let's talk about contour. And as I'm talking about contour, I'm talking about the back of the skin barrier. Is it flat or is it convex? This is convex right here. And in a second, I'm going to get into the new one, which is the convex flip. Yeah, for those contours that are out like this from a hernia. Yeah, so this is a little new technology that's come along since this presentation was created. Contour. How do we know if we want a flat or a convex skin barrier? Well, we're going to base that by a couple of different things. Number one, the stoma. Does the stoma protrude off of the body? Or is it flush or retracted? And then another thing I'm going to take into consideration, the peristomal plane. Is it flat or are there contours? Are there creases and folds, crevices, or scars on that peristomal plane? The back of a flat skin barrier, it's exactly that. It's flat. And I would use this when my peristomal plane didn't have creases or folds or imperfections, as long as I had a budded stoma. Your flat skin barriers, well, they're going to be more flexible because it doesn't have to have the buildup of the rest of the product that is going to make up a convex product. So they're going to be more flexible and they're also going to be easier to hide up underneath your clothing. Now, a convex skin barrier, it has this outward protrusion, just like this outward protrusion. So it pushes back on the skin. The reason it does that, when you look at these bottom 2 pictures, the one over on the left, you see a retracted stoma. And as the effluent comes out of that retracted stoma, it pools, P-O-O-L-S, pools right there as it comes out and then runs over onto the skin. Now, if you take a convex skin barrier and put it down appropriately over a stoma and press that skin down, it's going to cause that stoma to be able to protrude up a little bit. And that's what you're using convexity for. You're using it because you're trying to allow the stoma to be able to protrude through that opening a little bit to encourage the effluent to run down out of the stoma into the pouch, as opposed to just oozing out of the opening and running back behind the skin barrier and causing a leak. Convexity, I would use that on my flush or retracted stomas to increase the protrusion. I could also use it on the stomas that had a bunch of creases or folds or, cushiony, kind of soft areas right there around the stoma. When we're talking about convexity, some terminology that we use: depth, profile, flexibility, pressure, and construction. Let's look at these words. Depth. We're talking about how much convexity, because we've got different levels of convexity. We've got different types of convexity. They look different, the way that they're made. Let's see, let's get another one of these. Here's another one. And here's one as well. And there's a company that has one that's an oval type convex. And when for the depth of the convexity that we're talking about, if you remember that moderate convexity is 1/16 to 1/4 of an inch. Well, anything under 1/16 is going to be shallow convexity. And then anything over 1/4 of an inch is going to be deep convexity. Now, another new innovation that's come out is soft convexity. There's convexity that's just a lot more gentle on the skin. than some of these rigid products used to be. Now, am I downing the rigid products? No, I'm not, because their company is the one that came out with the soft convexity. All I'm saying is now convexity is a big game changer, because it used to be with these rigid types of convexities, we had to be so very careful, especially post-operatively, because you didn't want to put too much pressure on that mucocutaneous junction. But now we've got soft convexity, we've got light convexity, and it just gives us more options in that post-operative time to help get that good seal. The profile, well, we're talking about the gradient or the slope. The flexibility, you've got soft and you've got firm. And when you're talking about pressure, you're talking, is it high pressure or low pressure? And where is the pressure? Is there right here in the inner part of the opening, or is it out here around the peripheral edge, right here around the barrier rim? With your cut to fit or your moldable convex products, the convexity is made right into the skin barrier, and these offer firm support. They can either be cut or molded to the appropriate size, and your cut to fit or your moldable, that's great for those post-op stomas that are still shrinking down in size, or for those oval or irregular shaped stomas that you can't have pre-cut. But know that when you're cutting out convexity, and some brands more than others, it can take pretty good dexterity to be able to do that. With your pre-cut convex skin barrier opening, well, the convexity again is made right into the skin barrier, but the opening is pre-cut to a specific size to match the opening on the skin barrier. It also provides firm support, very easy to use, but you have to make sure that if you're using this on an irregular shaped stoma, that any exposed skin is covered and protected. Now, convex insert. Where is my convex insert? I have a convex insert, and to be honest, I rarely use convex inserts. As a matter of fact, I say rarely, I've never used a convex insert. And the reason is I can't get it to snap into the skin barrier appropriately. It's not one of those little snap and you're done kind of things. I have difficulty maneuvering it, and I've just always managed to be able to get around it. But if you would like to use one, a convex insert, it's this pre-sized little plastic ring, meaning you're going to have the one that is going to match the inside of your skin barrier. This one doesn't happen to match this one, but it would match your flange. What this does is it takes a two-piece flat skin barrier and it converts it into a mild, not mild, I don't even want to say light convexity, because it's just barely a little hump of convexity. But as you snap it into place, it's supposed to provide convexity. As it says down there at the bottom, it can be difficult for people to use if they have dexterity issues. I've never considered myself to be somebody with dexterity issues until I tried to work with that convex ring. But I've managed to get around it. You'll see that we've got plenty of other products that we can use in its place. And you know what? I can count on one hand the times that I have had a student raise their hand in the classroom and say that they had used them or they had been taught how to use them. So not a lot of us are using them. Now, a reusable faceplate. A reusable faceplate would be used in place of your regular type faceplate. These can be cleaned and reused. They do provide firm convexity. Again, they can be difficult to use with manual dexterity. These you're either going to use some type of skin adhesive or a belt to hold this onto the body. These are what come with your adhesiveless, some of your adhesiveless systems, and it can be difficult to snap the belt on and off of these at times. Now, you've also got custom made appliances. I had a custom made appliance out here on the side. This is one of your examples of a custom made appliance. Marlin made this one custom for someone. And this one would be an example of maybe the opening that they needed for their loop stoma, possibly. But this is just one example of a custom made appliance. It's an appliance that's made because there wasn't something in the regular stock to fit it. If you look at the picture and you look at the right side, the drainable pouch that's at the top, you see that its opening for the stoma is at a bevel. It's sitting right here on the side of that slope. And then they've got this big buildup. It looks to me like maybe the person had an incision that healed by secondary intention, you know, from the bottom up, and it left that deep divot in the body. And then their stoma is very close to it. Like I said, and it is right there on the bevel. Could you imagine having to use things like e-conceals and moldable barrier rings to fill that scar in to make a flat pouching plane on the person's body that pouch is designed for? You know, that could take 10, 12 of these moldable barrier rings or e-conceals. That could be $120 right there in these rings, not to mention the rest of the appliance that you're putting on there. But you can have these made. These last for a couple of months. You know, you simply clean them out and reuse them. People use these custom made appliances for different things. For an abdomen like that, it would just be out of the ease of not having to use all these accessory products. But you can see some of the products that you're looking at, those are just basic appliances. Well, people with limited funds use these as well because they can be reused. Now, you've also got something called a convex skin barrier. This is a convex skin barrier right here. These are soft and pliable. Now, they've got adhesive on both sides of them. You can take these and you can apply it. Let me apply it on this convex product right here. And you can see how I can take a convex product. So this is my convex product. And I am going to now make it deep convex. See, by adding this on top of it, I have made it a deep convex. Check that out. Yes, now I would need to fill in this little opening right there, but that's not what I was trying to show you. I was just trying to show you how I had increased that amount of protrusion right there. You can create that custom fit with these. Now, these have memory to them. When you stretch them, they're going to come back and retain their shape. Unlike this type of ring, you're going to see that this type of ring is kind of like a Play-Doh. You form this and mold this to whatever size you want. Convex barrier rings have memory. This one was circular, but the one in the image down there on the bottom is an oval shape. So you can get these cut out for that oval shape. Another product that we see there is the seal tack. This is the seal tack right here. When you pull it out of the package, it also has memory. But something you need to know about this one, when you're pulling it out of the package, it is going to usually, that one came out pretty easy, but I think it's because I've taken it out a couple of times. These stretch all out of whack, but they come back and retain that shape again. Yeah, memory. Okay. Both of these are convex barrier rings. These convex barrier rings add convexity, but these don't break down. They don't break down. They're not as soft. You know, now this one is made of silicone, but so it is pretty soft. The one by Hollister right here is not soft. Sometimes you don't want something soft. Sometimes you're going to need something rigid. Do you remember the two images that I was contrasting? One was a younger boy that had a firm abdomen, and the other was an older person that had that crepey skin with poor skin turgor. It's going to take something like this for that crepey skin. When would I want to use convexity? I would want to use convexity if there was no protrusion of the stoma. Can you cut these? Yes, you can. Yes, you can. If you need to cut them, you can cut them. If you only needed, if you needed more protrusion or more convexity on one side than the other, absolutely, you can cut them. But you can't mold them the same way that you can mold Play-Doh. But yes, you could cut them. I would use convexity on that stoma that doesn't protrude, on the stoma that's retracted, or the stoma that's right there at the skin surface. I could use it on that stoma that has a lumen on the side, or definitely use it if I had a peristomal fistula. I could use convexity if I had that peristomal plane where it had soft or poor muscle tone, or there was uneven areas, maybe some creases or divots in the skin. But I wouldn't want to use it on a regular stoma, and I wouldn't want to use it on a peristomal hernia. And that's what you're looking at in the picture right there. A peristomal hernia is where you have loops of intestine that's gotten into an area of the body where it's not supposed to be, and it's just kind of hung there. We'll look at that tomorrow. I've got to be careful when I use convexity on those post-op stomas. This is where that light and soft convexity has really changed everything for us. But you also have to be careful with convexity whenever you've got varices, an ulcer or a wound, and pyoderma gangrenosum. You have to be really careful and not cause mucocutaneous separation or make it worse with convexity. And we don't use convexity when we have a stoma prolapse because we don't want to put the pressure on there. With convexity, you know what? They are a pressure device. This is a medical pressure device, and the skin can show the signs of wear and tear from it. You can easily have skin breakdown, bruising, erythema, and it can cause pain to the skin. Your convex products are not going to be as flexible as your non-convex products because of the extra materials that it took to make it a convex product. And as I said earlier, they do require more dexterity. We usually recommend the use of a belt or a binder to enhance the convexity. Again, remember, convexity is a pressure device, and you would never put your patient in a pressure device without following up on them. So don't put somebody in convexity and send them off into the wild blue yonder with a good luck. You want to follow up with this person and make sure that that pressure device didn't injure their skin. Hey, quick question. What's this product? Convex barrier ring. Very good. Very good. Okay, now let's talk about pouches. We talked about the skin barriers, but let's talk about the pouches themselves. They're the containment device that's going to hold the urine, the stool, the mucus, the gas. And as I said before, they come in one-piece or two-piece systems. With your two-piece system, the skin barrier is going to stay stuck to the skin, but the pouch comes off. And if it was just a clear, transparent pouch, it could be washed and dried and reused. But if it's got the opaque material on it, which is your, non-textile type material, you wouldn't want to wash these. They do absorb some of that moisture. So if anybody is going to wash and reuse the pouching system, again, it needs to be two-piece and transparent with no filter on it either. We'll talk about filters in just a few minutes. When you're using a two-piece pouching system, you want to make sure that you've got Convatec with Convatec and Hollister with Hollister. You don't mix and match these products together. You don't. They aren't interchangeable. Each brand is brand specific. So yes, you might be able to get that Hollister pouch to snap on to that Convatec skin barrier, it won't stay. It's gonna be like that Tupperware bowl and that country crock lid. You're gonna go in there in the morning and open that refrigerator door and everything's gonna smell like broccoli. Yeah, because you know nothing doesn't fit that Tupperware bowl but that Tupperware lid. Yeah, there's a reason for that, and that's so you will use the products together. Coupling's a word we use a lot when we're talking about ostomy. That's bringing these two pieces together. The flange coupling, I've talked about that already several times. I showed the Hollister skin barrier and pouching system. Where did I put it? Right here, that was the one with the floating flange. Well, here's my flange there, and then here it is right here. This is the floating part. These two pieces just snap together. I've also got something called adhesive coupling. Now this is adhesive coupling right here. And with adhesive coupling, there are these little tabs, this little teal colored tab. It tells me where to put my fingers. And I'm gonna pull the two pieces apart. Here we go. Did you see that? That's adhesive on the pouch part. And the skin barrier just has this landing zone. I'm pulling the back of it back. And this is the part that would stick to your skin. And I'm pulling it back so you can see this flexible landing zone. And the landing zone is where this adhesive is going to stick. And I can stick it on there just like that. And this is another one of the products that I feel, and then I hold it and try and get somebody to pull it off. These stick way better than I ever thought that they would. Now, the great thing about adhesive coupling is it offers the best of both worlds. For the person that wants that two-piece system, maybe they have problems lining it up, and so it works best for them if they put their finger through the skin barrier and then touch their stoma and slide the skin barrier off onto it. So they need that two-piece system, but they like flexibility. Well, watch how flexible this is. Look at that. Look how flexible. Yeah, so they don't lose the flexibility here with adhesive coupling. Adhesive coupling is available from Coloplast, Convatec, and Cymed, C-Y-M-E-D, Cymed. Your one-piece pouching system, everything is made together in one piece. They don't come apart, and if they do come apart, oh my goodness, throw it away, because if you just snap it back together, it's going to come apart on that person. These are usually your most flexible. They're also the most low profile as well, easier to conceal up underneath the clothing. With your one piece, that's what's going to be recommended for your patients that have manual dexterity issues or visual problems. And typically when somebody has visual problems, we're going to teach them with a one-piece pouching system because it's fewer parts, and meaning it's just one piece rather than two pieces to connect together. And we are going to try and get a filter put on there so the person doesn't have to burp it open. If we could get it closed-ended, they're not going to have to empty it. Now look at this one piece closed-ended pouch right here. One piece closed-ended. When the person goes to apply this pouching system, I'm going to stand up. Since you can't see through it to apply it over the stoma, what most people do is kind of fold it in half like this, put it up under their stoma, and then lift it up just like that. Now again, go around it with your hands and make sure you're sealing everything down really good. Remember, gentle pressure to make sure that you've got a good stick. Your closed-ended pouching systems, well, I've got this one in my hand. Your closed-ended pouching systems, these are designed for one-time use. They are supposed to be removed and discarded when they're 1/3 full. These are available in one-piece and two-piece systems. Ideally, your closed-ended pouches are not recommended for ileostomies or urostomies. Closed-ended pouches are designed to be used for special occasions or intimate moments, or for travel, or for the person that has a colostomy. They wear closed-ended pouches quite often. They simply remove them, throw them away, and put on another pouch. Now, your drainable open-ended pouches, these are the ones that are typically going to be used by somebody that has an ileostomy. And these are designed to be emptied when they are 1/3 of the way full. So I've got different types of closures here. This is one. And notice how much wider this opening is than this one right here. Do you see that? That looks like just a little bit. But you know what? When it comes to dropping thick stool out of it, that 1/4 of an inch makes a bigger difference than you would think. Drainable open-ended pouches, as I said, they're designed to be emptied when they are 1/3 to 1/2 full. We do encourage the person to empty it at 1/3 full because 1/2 is a lot of weight in a pouch. Your drainable pouches are designed for ileostomies and your urostomies. Urostomies would have a spout on the bottom of them. Closures have come a long way, and you want to experiment with different types of closures. See what's easiest for you to work with to know what you're going to want to recommend from one person to another. And when it comes to the different closures, there are so many different ones. There's the Velcro, that when you want to empty the pouch, you engage these 4 pieces of Velcro, kind of open it just like grandma's change purse used to open. And you would empty everything out. After it's emptied, open back up the Velcro, fold this over, roll it down, close it up. Now you do have a little piece of Velcro tucked away up underneath here. There you go. So you could put that in there and fold it away. It kind of holds that Velcro up and out of the way and does make this a little bit shorter pouch right here. But your different manufacturers have different kinds of Velcro. This is by Hollister, and it was called the Lock and Roll. This is the one by Marlin right here. It's not a Velcro, it's a hook and loop type closure, very similar to Velcro, hook and loop. There we go. You would roll it, roll it, roll it, and then just fold it over. So different brands have different types of closures. Like I said, you squeeze it on the side like grandma's old change purse used to be. And where's me another one? Here's one by Convatec. Now this one kind of has a dual closure on it. You would empty it out. To empty it out, there we go. We would empty it. After we've emptied it, we want to clean around the inside of it, clean around the outside, and then we're going to roll it up, and take this piece of Velcro and tuck it away. There we go. Whoa, I dropped it. I folded it up. Now I can tuck it up underneath that front closure. There we go. To be honest, I was sweating that one out because I realized, oh, I didn't practice with that one. So, you know, it is kind of risky when you're doing it in front of somebody to make sure that you're rolling it the proper way. And because if I was rolling it backwards, it would not have snapped correctly. But luckily that one did. That one did. The curved tail closure. So now we're talking about the different types of clamps. This is a clamp right here that has the curved tail closure. Notice that it's got a contour. And the reason this clamp has a contour is it's contoured with the body. So please make sure that you do have it contouring with the body and not against the body. Nobody needs this laying down on their abdomen up like this. All right, you're supposed to put it on and it contours with the body. That means you've got to think through the steps that you're doing and how you put this on so it comes on correctly. So do work with this clamp to make sure that it ends up with the person's contour, not against the person's contour. So many people don't even think about that. But for this to be inconspicuous up underneath the person's clothing, yeah, that really is a good idea. But there's other types of closure clamps as well. This was Hollister's. This is the one by Convatec right here. Typically with your clamps, you are going to get 1 or 2 of the clamps in your pouching systems that are drainable that require a clamp closure. Typically, that's what's in there. Now, what is up there in the very top picture is a disposable clamp. And that's what this is right here. It's basically a piece of covered wire. It's got a little bit of adhesive right here. And the adhesive on that is behind that white square. I would take this and I would stick it to the bottom of a drainable pouch. Let me peel this off and do this for you. Okay, so here is my drainable pouch. I would put this on the bottom of my drainable pouch. And then I would be able to roll it up. It's hard to do when you're doing it with one hand. There we go. I would roll it up and then fold this back on itself. Yeah, just like you do that tasty donut bag. Yeah, look at that. Look at that. There you go. Tasty cake donuts. Yeah, same way you close their little bag up. Same way. That is a disposable clamp. You see, when a company is going to send you just 1 or 2 pouches, they are probably not going to send you an actual clamp to go along with it. They'll probably send you those little disposable clamps. And they work just fine. As a matter of fact, you want to collect some of these because there's going to come a time that your patient is going to lose their clamp and you may not have enough of them built up. Now you can say that they can use a rubber band on the end of their pouch. Something that is very popular on pouches are these binder clips. I never would have thought that they're as popular as they are. Some people put them over the traditional clamp. That's how they use them. But some people just use the binder clamp alone on the bottom of the pouching system. Now, when it comes to your urostomy pouches, you've got several different types of spouts. This is the one that's the wing right here. And when it's in the open position, you can see the little dot on it. There's also one from Coloplast that looks like a little screw. That would be this one right here. And it doesn't actually screw in. Those treads just help it hold better. There's also a pull, and I've got that in the drawer. I'll get that during break. That one's by Marlin. And then other types of closures that you have. On your high output pouches, you've got closures like this. Now, again, this one looks like the screw, but what I want you to notice is the size is so much larger. This is a regular urostomy spout, and this would be one for high output. Yeah, quite different diameters there. Here's the screw closure. This is the wing closure, and it's showing you in the open position. You can see that little drop. With your urostomy pouches, the urostomy pouches have this feature called an anti-reflux device. And the anti-reflux device on this one is built right in through here. You can see the anti-reflux device on the pouch in the screen and the 3 little dots that are just above that line on the left-hand picture. The anti-reflux device is designed for this purpose. You know, when the person has urine in their pouch and they lay down, well, the urine could just run right up here to the top. And if they're wearing a convex pouching system, the urine is going to pool in here and just start to try and erode the skin barrier. Oh, they would be wearing extended wear. You know, it's erosion resistant. But hey, if urine is just going to sit there for, let's say, 8 hours, that's risking some leakage right there. So when the person with urine just lays down and the urine runs back up here, well, that can contribute to leakage, failure of the seal. So it would be great if we could keep the urine in the bottom part of the pouch. Well, enter the anti-reflux device. So as urine enters into the pouch from the stoma, it falls down to the bottom of the pouch. And when it goes down past this anti-reflux device, the anti-reflux device acts as a one-way valve to allow the urine to come down to the bottom of the pouch. But when the person lays down, it prevents the urine from being able to run back up to the top of the pouch. Anti-reflux. Now, we do recommend that the person at night connect to nighttime drainage. So that's going to allow the urine to just exit the pouch. And it won't need to be empty during the night. It'll give that person with a urostomy a good night's sleep, actually. But what I'm talking about is the anti-reflux device, encouraging the urine to stay at the distal end of the pouching system to discourage it from running back up, pooling over the skin barrier and causing leakage. As I said, we definitely recommend a person with a urostomy hook up to nighttime drainage. And as they hook up to nighttime drainage, all of your manufacturers have some type of adapter. So their pouching system can adapt to that nighttime drainage system. Unfortunately, there's not a Christmas tree because we don't have a universal type opening there. Some of your systems have these little places right here where they need something to connect to, like the image right there at the bottom of the Hollister one. But I don't have that on the one from Coloplast. I think it's the one from Symed. Your adapter is nothing but a little piece of plastic. Nonetheless, all the manufacturers of the urostomy pouches have an adapter that you'll be using to connect it to nighttime drainage. Okay. Now is actually a good time for us to take a break. What do you say? Y'all want to take a break? Give me a yes or a no. I bet I know what you're going to say. Okie dokie. All right, let's take 15 and we will, the butterfly or the crescent has kind of a hinge on it. So I can fold it like that. I would fold it like that. That's folded when it's inserted. It's inserted and then it's laid flat, typically sutured down. So when it's time to remove this one, again, remove the sutures. And then this one would be folded, turned to the side, and slid right back out again. There you go. Let me put this one back in to be done with it. And there we go. There we go. So give me a sentence on what you think about removing the rod. What do you think about removing the rod? I've been doing this for about 20 years. I have removed 2 rods in all of my time. One of the rods had been left in by mistake. The woman was from a long-term care facility. She had a loop ileostomy done. They left the rod in by mistake when she went back in for, it was supposed to be left in because the woman had been taking steroids. So they were afraid that she would have delayed closure. So they left it in until it was time for her evaluation, her post-op evaluation visit, typical 6-week visit. When she went back in, the doctor wasn't in and the PA didn't remove her pouch, left the rod in, sent her back to long-term care. And it wasn't until I was consulted because somebody thought that there was a wound that had pus draining out of it. They saw mucus draining out of the distal opening and they thought it was pus. The lady had that rod in, are you ready? 8 years. 8 years. Those nurses at that long-term care had been pouching around that rod. Now the sutures had long come out, so they were pouching it up underneath it. Do you know what the skin looked like under that rod? Impeccable. Those nurses could not have done a better job than they did. I called the surgeon's office where they told me the surgeon worked because I didn't recognize the surgeon's name. Well, the surgeon had retired years before. So I spoke with one of the other surgeons that was there, and he told me I could go ahead and remove it. All I had to do was move the swivel. It was one of these swivels. All I had to do was undo the swivel and slide it out. That was all there was to it. But that was a big thing for those nurses that had been pouching around this for all those years, just to make it so easy now for them to pouch. And by the way, the lady's stoma looked great. The other time I removed a rod was last year. Actually, it was a woman again who had been taking steroids, so it wasn't to be removed until after 6 weeks. And when she went back into the doctor wanted to leave it in for a couple more weeks, so they had me go out 2 weeks later and remove it. So it's not very often that we're called to do this, but when we are, we got to know how to do it. Carissa, you've done it a couple of times. Yeah, cool to do, cool to do. Now you do need an order to do this, so make sure that you have an order to do it. But it's a big relief for that patient as well. And by the way, if you ever get to your patient's home or the patient tells you, you know, I'm supposed to have my rod left in for a couple of months, question that. Go ahead and call the doctor's office and question that, because people get confused. People get confused. So don't be afraid to question it. For our patient education, our last section on Wednesday is going to be patient education. We're going to talk about the importance of return demonstration and making sure the patient understands what you're trying to teach. We're going to emphasize that you do this in a quiet, well-lit environment, and emphasize how what you're going to teach one person is going to be different than what you're teaching somebody else down the hall. Some patients are eager to just jump right in, and then you've got the others. It's going to be baby steps, baby steps. So this is very, very individualized. Let's watch our last video for the day. Let's cross our fingers and hope it's working. If it's not, you know I'm going out and coming back in. All right, our last one for the day is about patient appliance application.
Changing a pouch. Your entire one-piece and two-piece drainable pouch will need to be changed every 3 to 5 days. If you see any output or leakage around the pouch, or if you feel any burning or itching under the barrier, change your pouch right away. Just how long you can wear a pouch system depends on how full you allow your pouch to get, how much you sweat or perspire, and how smooth or uneven the skin is around your stoma. Decide on timing. You'll also need to decide on timing pouch changes. For ileostomy and colostomy, it is easier to change the pouch when the stoma is less active, such as the first thing in the morning before you eat, or 2 hours after eating. For a urostomy, you will always be producing urine, so the pouch and barrier can be changed anytime. Gather supplies. Changing your pouch system is much easier when all your supplies are handy. So the first step is gathering everything you'll need. A new pouch, something to clean your skin, such as a damp washcloth or wipes, a sizing template to measure your stoma and size the opening, a pen to trace the size of your stoma, scissors for cutting the opening, and a small disposable garbage bag. Though you may not need them, some people use skin paste to fill in any body folds, skin powder to place on red or wimpy skin, and pouch deodorant. Okay, now would be a good time to pause and gather all of the supplies you would need to change a pouch system. After we show you how to remove the pouch, we'll practice placing a new pouch on the ostomy practice model. Remove the old pouch. To remove the old pouch, begin by peeling away one corner of the barrier. Then work around the rest of the barrier, pushing down on the skin at each point, while at the same time pulling the barrier away from the skin. Some people use a cloth or gauze to push on the adhesive as they remove the barrier. Lastly, place the used pouch into a disposable waste bag. If your pouch has a closure clip, be sure to save it. Clean and inspect the skin. After removing the old pouch, look at your stoma and check the color. It should be red and moist. Also, check for any bleeding. This is rare. Then check the skin around the stoma for any redness or irritation. Your skin should look like the rest of the skin on your abdomen. After inspecting your skin, clean it with water and a washcloth. Do not use scented soaps, oil, or alcohol. Then gently pat your skin dry. If the skin around the stoma is irritated or weepy, you can apply some stoma powder to absorb the moisture. Remember that your new barrier will not stick well if your skin is moist. Measure and cut the opening. Next, measure and cut an opening in the fresh barrier. Most skin problems are caused by the ostomy opening not being cut to the right size. So it is important to measure the stoma and make sure you have the right fit. So let's do this together. You will need the stoma practice model, pen, measurement guide, scissors, and pouch from your skills kit. Measure the stoma. Use your sizing template and determine the size of your stoma. You should be measuring your stoma practice model. Find the size that fits closest to the edge of the stoma where the skin and the stoma meet. Next, place the template on the back of the pouch barrier and trace the correct size. Use the scissors to cut an opening in the barrier closely following the traced shape. If you're using a one-piece pouch system, place your finger into the small pre-cut opening and push away the pouch before you start to cut. Be careful not to cut through the front of the pouch. If you do cut the pouch, do not try to tape it closed. It will leak and also emit odor. Center the new opening over the stoma to make sure it fits along the stoma edge. For the first several months, your stoma will continue to shrink in size as swelling goes down. So in the beginning, you will have to measure your stoma with each pouch change to make sure you have the right size opening. After that, you'll be able to pre-cut your pouch opening from your template or order pre-cut pouches. The opening should fit very close to the edge of the stoma to prevent skin irritation. If your stoma isn't perfectly round, work with your ostomy nurse or doctor to make a custom template. Applying the new pouch. Now you can attach the new appliance. If you notice any skin redness or weeping, apply stoma powder before you attach it. Start by removing the paper from the adhesive back of the barrier. In this case, we have inner release paper that gets removed first and outer release paper that gets removed after that. Do not remove the side tabs. Next, center the cut opening over the stoma. Place the barrier on the skin around the stoma, hold it in place, and press down on all sides for about 30 seconds to make sure that it is firmly applied. Then, in this case, remove the adhesive side tabs. Now, raise the bottom of the pouch and close the opening. Some people wear a pouch belt to secure the pouch. You can date and keep the paper from the back to use as your template for the next pouch change. Okay, so let's pause as you measure, cut, and apply your pouch to the ostomy practice model.
Okay. Again, this video is on the DVD in your skills kit. And that brings us to the end of today. And I bet you are glad I don't have any more videos to fumble through. I certainly am. I certainly am. Okay, question time. True or false? Stoma measurements should be recorded in centimeters or millimeters? Centimeters or millimeters? What do you say? True or false? T or F? Yay or no? False. That's right. Millimeters or inches. Very good. Millimeters or inches. True or false? Stoma size can change with weight gain or weight loss. Now the stoma size can change with weight gain or weight loss. Yes, it can. It can. Remember the infraumbilical fat mound, that's what doesn't change much, but the stoma, yes. Pouches should provide predictable and reliable wear times. True or false? That's true as well. Very good. How about create a pinhole at the top of the pouch for the release of flatus? Do we want to do that? No, not unless we want a mess all over the place. So we don't do that anymore. Now we use pouch deodorants. And by the way, for liability purposes, I only recommend manufactured type deodorants. I don't recommend certs, Altoids, Tic Tac, deodorant. I don't do that. If somebody tells me that they're doing it, I'll just go, oh, well, I'll be. But I'm not going to be giving that suggestion. If for some reason it were to cause a problem for that person, there's no evidence to back me up. So for that reason, I'm just not going to be the one suggesting it. Okay. Products are free to ostomy patients, so cost is not a concern. True or false? That's false. Yeah, cost is quite a concern for people. How about this? A trained clinician's role is to educate on product selection and application techniques throughout the patient's lifetime with an ostomy. Yeah, that one is true. That one is true. Okay, what is the optimal stoma height? Let me give you a little hint. You haven't seen it written like this yet. Optimal stoma height. Drum roll, ladies. No, Carissa, guess again. Guess again before Jennifer gets her answer up there. Guess again, Jennifer. Carissa was right. A is your answer. A is the answer. There you go. There you go. All right. A stoma that's located at the skin surface is called a what kind of stoma? There you go. A flush stoma. Very good, ladies. What's the name of this? Oh, I'm sorry. That's not what it's asking. What's this product used for? Yeah, creating custom convexity. Very good. What's the proper method to measure a round stoma? Very good, the diameter. The optimal location for the opening of the stoma is at the it's at the top of the stoma. At the top of the stoma. Patient says, I hate this yucky paste under my plants. I think I'll just tape it on. The most informative response to this remark would be which of the following? Now, ladies, there's two answers that sound pretty good, but one of these gives more information than the other one does. Very good. B is the answer. B is your answer. Okay. Which is not a recommended use for a cut to fit skin barrier? In other words, who on here could be using something other than a cut to fit? Mm-hmm. Mm-hmm. B is the, I'm sorry, D is the answer. D is the answer. Okay, which is not a recommended use for a cut to fit skin barrier. It is worded kind of weird, Jennifer. It might have thrown you off. That 2-week stoma, well, that 2-week stoma is still shrinking in size. I need a cut to fit skin barrier for a 2-week stoma. An irregular shaped stoma, I'm not going to get that pre-cut, so I'm going to have a cut to fit for that irregular shaped stoma. Well, a stoma that's not round, would that be an irregular shaped stoma? Again, a cut to fit. So a round stoma after 8 weeks, hey, after 8 weeks, its shrinkage has happened. Don't think that's the term for it. No, that's not the term for it now that I think about it. The post-op edema has resolved, okay? There we go. That's what I was thinking. The post-op edema has resolved, and they can go with one that is pre-cut. All right, your patient has a colostomy and has been using an extended wear barrier. Appliance removal has created some skin trauma due to the high adhesive levels. You suggest trialing let's do that. A standard wear barrier. Very good, ladies. Okay, your patient has a urostomy and comes to you with pouch adherence issues. He's been using a standard barrier and he's changing the pouch on a daily basis due to barrier erosion. You suggest a trial of an extended wear time barrier because they are more erosion resistant. Very good, ladies. Very good. You know what, you two? I've got a good feeling about you. I really, really, really do. I have a good feeling about you two. Okay, tackifiers are components of skin barriers. They provide the stickiness so the barrier will adhere to the skin. To activate the stickiness, you should that's it. Apply a little bit of pressure when applying it to the skin. Which type of system is considered a pressure device and needs regular monitoring? That convex system, that's it. Which of these situations would not be recommended for the use of a closed-ended pouch? Yeah, a urostomy, that's right. Drainable open-ended pouches are recommended for patients with urostomies and ileostomies due to yes, the liquid consistency. That's right. When pouching a patient postoperatively who has a loop stoma with a rod in place or a urinary stoma with stents, you should select those pouching systems that will include these devices. Next, a pouch lubricant is sometimes needed. Yes, facilitate the ease of emptying the pouch. The use of baby oil, pan cooking spray, mineral oil, or cooking oil is not recommended in pouches because they can cause the seal to fail and odor. Very good. Stoma paste is used like caulking to improve the seal around the barrier. It is not Nope, it is not adhesive. So very good, ladies. Stoma powder can be used to dry those moist areas and help with sealing. Okay, the best time to change an appliance is When the stoma's least active. Ladies, give yourselves a hand. Give yourselves a hand. Okay. Again, I apologize for the technical issues. I'm thinking it had to do with the update that I did, so I am going to take it to my IT guy tonight, and hopefully we won't have those issues tomorrow. Again, I can't apologize enough. I know how irritating it was for me, so Jennifer and Carissa, my guess is it was irritating for you too. Now, I will be doing the review in the morning. Are y'all interested in doing the review? Yes, you are interested in the review. Okie dokie. I will be signed on at 7:30 and I will begin my review at 7:40.